You guys can stand there. You can stand there if you want. You can stand here. Good morning, everyone. Welcome to the 2023 Global Health Catalyst Summit at the University of Pennsylvania. We're so happy to have this summit here. This has been years in the making. I think originally COVID disrupted our schedule, therefore we couldn't have it. I just want to acknowledge my co-chairs. First, Professor Saiful Huq, who is a past president of the American Association of Physicians in Medicine, and this year's Coolidge Award winner, which is the highest award you can win in medical physics. So we're very happy to have him part of our team. And also Wilfred Inqua from Harvard and Johns Hopkins. This is the founder of the Global Health Catalyst. Dr. Inqua is the one who started all of this, and I think that we never imagined it becoming this big. So I want to thank Will, and we can continue growth. So the word for the next 3 days is collaborate, and I think for the next 3 days you'll hear about projects, people working together, people showing the outcomes. I'll look at your neighbor to the left and right and see if that person is willing to collaborate with you in the end. But the Catalyst Summit is about working together on projects. It's not just about coming and talking, it's about doing. And so I think that if you've been here before, welcome back. I think that you kind of know what's going on. If you're new, I think you're going to enjoy the experience for the next 3 days. So we're going to start with opening remarks. First, I would like to welcome my chair of radiation oncology here at the University of Pennsylvania, Jim Metz.
Thanks, Steve. Welcome to the University of Pennsylvania. It's a pleasure to have you all here and host this Catalyst Summit this year. I have a couple of brief stories to kind of pull things together to start off. And I've been very pleased with how our Department of Radiation Oncology has gotten involved with global health over the last number of years. And to go with this summit of being a catalyst and how things come together inside conversation, I'm going to share with you a couple of stories of how our department really moved forward with this. So a number of years ago, I was in a meeting in Africa at the aortic meeting, and some nurses came up to my nurses and asked for some help in education, in developing educational programs. And we got involved, and we're back and forth in developing those educational programs for a while. And I came back to the University of Pennsylvania, and I ran into Steve in the hall. Steve, I don't know, this is 15, 17 years ago, something like that. And he was asking me what I was doing over in Africa, and we talked about it. And Steve kind of nodded and says, oh, that's interesting. I said, and there's a real need for developing programs in physics in Africa. He goes, okay. And Steve walked away. And then a few months later, we get back together, and all of a sudden, he's got relationships with Harvard, he's got relationships with Hopkins, he's developing a master's program in Tanzania, he's got all kinds of things going on, and the passion that ignited in him is really amazing, to where he's now co-director of this program. So to see that evolve over the years is so important, and again, it's those side conversations that you see evolve, and that's why that's so important, as Steve just said a few minutes ago. A couple other people in my department have inspired me over the years, one being Serby Grover, who's also here, who was a resident in our department and has really become a leader as a physician in radiation oncology internationally, and working in Botswana for the last 8 or 9 years. And I've seen her evolve her research programs and multidisciplinary programs, which has really been amazing. And what she's taught me too is we need to have a pipeline of people. And we've worked on this in our department, in that, she's becoming a more senior member of our department. We need to have junior faculty. We had medical students and undergraduate students who were very interested in global health, but we had to build this pipeline, and then we developed a global health program for our residents. So now we have everything from students to residents to junior faculty to her mentoring this group. But the pipeline is critical in how we think about that pipeline going forward. And another person that I need to thank, that this conference would never happen without, is Cordy Baffick. I don't know where Cordy is, but Cordy is the one who pulls all this together. Where is Cordy? She's out there somewhere. She's running around making sure this all works. But we couldn't have done this without Cordy and helping Steve go along, as she's really a detail person and made this all come together. So thanks so much for doing this, Cordy. Again, I really want to welcome all of you, and please take advantage of the side conversations. That's where things really happen. I think the talks up here are going to stimulate you to think about things, but how you collaborate, how you get together with people on the side at lunch, at dinner, at the breaks, please do that. And we look forward to seeing that evolve. I know we have people online also, so hopefully you'll be able to engage with us well through this conference going forward, but coming up with those ideas of who to work with down the road is critical. So again, welcome to the city of Philadelphia. Welcome to the University of Pennsylvania. And I look forward to, in a few years, looking back and saying what came out of this conference at Penn, what collaborations happened in Philadelphia that we can look back to and be proud of in the future. So thank you.
So next we're going to have a video from the chair of radiation oncology at Johns Hopkins, Akila Viswanathan. And I think that we are going to lower the lights and play the video.
Welcome to the Global Health Catalyst Summit. We are so excited to see you here today. My name is Akila Viswanathan. I am the Department Director of Radiation Oncology at Johns Hopkins, and welcome to all of you. We're so excited that Dr. Will Negwa has partnered with many, many great leaders and with all of you to bring everyone together to advance cancer care in Africa and around the world. There are so many important things that we need to address and address urgently in order to provide better care, higher quality care, and really meet the mission that we all have in our hearts of taking care of others in the best possible way. So welcome. We look forward to hearing all of the great ideas and coming forward with concrete suggestions for things we can build and build together in the best possible manner. Thanks for being here and look forward to great discussions.
Dr. Viswanathan is actually here. She'll be participating in one of the sessions later today. So next, I'd like to bring our director for the Center of Global Health, Glenn Galton, for some opening remarks.
Morning, everyone. Thank you, Stephen, and the other organizers for bringing us all together again. I'm really Jim's counterpart at the broader level of Penn Medicine, which is the combination of both our School of Medicine and the University of Pennsylvania Health System. And like most of your institutions, and Penn is a very large one, we have almost 3,000 faculty plus in the School of Medicine alone. We have many individuals working around the globe on really impactful projects. And a big chunk of that, not surprisingly, occurs in the cancer space. But they often work in disconnected kinds of ways. And when you have great leaders like Dr. Metz, you can bring together a department. So how do institutions bring all of this together? And one of the initiatives that the NIH in particular has encouraged is to really foster development of cancer initiatives globally within cancer centers, which of course, exist at many places throughout the US. Now, if you're writing a renewal to your cancer center grant, you are for sure going to have a section on global cancer in that grant. But what's really happening in those domains, and how united is the effort, and how do we think about, as institutions, about bringing people together and garnering institutional support, both by things like away time for people to work, when they're not performing their services here at their home base, as well as, to synergize between faculty working across specialties. So I suspect, need to tell this audience much about the complexity of I'm going to say cancer care, but it's really awareness, diagnostic, prevention, care, and long-term follow-up, and the multiple specialties that are involved in providing appropriate care for individuals. How do you bring all that together? It's a daunting problem. I've been involved directly in an effort in Southeast Asia to bring together a center of excellence in cancer, and it's just staggering. I'm by the way, by background, virologist and immunologist, so cancer was not my deal, as they say. And And I think that's one of the things that the summit is really, really good for, is to have those conversations. Because I've actually been struck sometimes about how the medical oncologists don't always talk as they should to the radiation oncologists. That's just one simple example. Not to call out anybody at Penn, but I suspect this is happening in many places, around the world. So this continuity needs to be bred. So one of the things I'm really, really pleased to tell you about is we participated in the symposia summit now for how many years has Penn been involved? From the past 3 summits. Yeah, the past 3, and I think I've either welcomed or spoke or listened, and certainly listened in to all 3. This catalyzed our effort within the institution to create a global cancer program that isn't just within our cancer center, but is within all of Penn Medicine. So we've had a strategic planning process. We're really, really pleased about the way that's gone. It's brought together individuals from throughout our community, and we'll be launching that program this coming July at the beginning of our new fiscal year. And it will talk both about places where we work and partners that we have and how we can help them do more and do better, recognizing that every location, every institution is different and has different needs. And simultaneous with that, it's building the backfill of our great people here at Penn and at our other partner institutions. So I think the summit, frankly, is tremendously powerful in that regard because it brings together academicians, industry folks, NGOs, et cetera, our federal government and others to bring forward. Many of you may have seen the NIH report. I'm sure most of you did in cancer, the 2001 report. I think the numbers they bounce around a little, and of course the report was 2001, so the data is a teeny bit older. Somewhere between 500 and 600 projects that were defined in this report happening in the global cancer space. Some 25 to 30 different programs within US institutions focused on cancer. So my hope also is that those programs start to get together as well, because no one institution, even as organized as any of us may be, can do this alone in supporting, supporting our colleagues around the world and having a real impact on improving cancer diagnosis care, prevention, diagnosis, care, and outcomes. So I want to welcome you as well, along with Jim, to Philadelphia. Here's the good news. It may not seem like it's warm to those of you coming from sub-Saharan Africa, as an example, but this is actually going to be a relatively warm day in Philly for our last few weeks. You are right on the edge of campus, by the way, so if you go back out the front door and just wrap around, our campus is right here, and it is one of the most beautiful urban campuses in the world. So I want to encourage you at the break and lunch, et cetera, to take a walk around the campus. So welcome to Philadelphia, welcome to Penn. Thanks for coming.
I want to second the comments about the weather. This is probably the best weekend that we've had in a while. If we were here last weekend, you may not have come back. It was not a good weekend. So I think Saturday is going to be the most gorgeous day. It's going to be mid-60s, sunny. So I think that says something, that the gods are on our side when the weather is nice also. So next, I would like to bring up Dr. Amy Gatson. She's representing Penn Global, as well as the Office of the President of the University of Pennsylvania. She's Associate Vice Provost for Global Initiatives and also Executive Director of the Penn China Initiatives. So thank you, Amy.
Good morning, everyone. It's my pleasure to be here to represent Penn Global, the Office of the Provost, and the University President, to welcome you. Our mission here at Penn is to bring the world to Penn and Penn to the world. And clearly, this conference achieves both goals quite successfully. In Penn Global, we have been seed grant supporters of Dr. Avery's work and also Dr. Grover's work. And it's really quite wonderful for us to see this broader network, this global network that's being built to support global health. I have a letter from our president, Liz McGill, who unfortunately could not be here this morning, but wanted me to share this with all of you. Greetings, distinguished guests, esteemed colleagues, and friends. It is my great pleasure to welcome you all to the 2023 Global Health Catalyst Summit at the University of Pennsylvania. At Penn, we believe that global cooperation and collaboration are critical in addressing the most complex and pressing challenges of our time. We are honored to have so many stakeholders, talented individuals, and organizations here with us to share their knowledge and catalyze solutions. I want to extend a special welcome to the ambassadors representing different countries around the world and those who have traveled internationally from over 30 countries to participate in this important event. This year's summit has a very significant theme: Cancer Moonshot 2.0, win-win collaborations to advance global health and development, which highlights the urgent need to address the growing impact of non-communicable diseases on global health and economic development. Cancer continues to be a leading global health crisis, causing millions of deaths each year and imposing significant economic and social burdens on individuals, families, and communities. The Lancet Oncology Commission report for Sub-Saharan Africa, developed in collaboration with faculty here at Penn, highlights this growing crisis, including calls for urgent action and collaboration. The Cancer Moonshot 2.0 initiative represents a bold and ambitious effort to accelerate progress in the fight against cancer. Through innovative research, collaborations, and partnerships, we can develop new and effective ways to prevent, detect, diagnose, and treat cancer. Over the next few days, you will hear from a diverse range of experts and practitioners who are working towards this goal through research, advocacy, policy, and practice. We will explore innovative technologies and multidisciplinary approaches that can benefit communities worldwide. I encourage you to engage in lively discussions, ask questions, and share your own perspectives. We all have a vital role to play in creating a healthier and more equitable world. Thank you again for joining us here at Penn for the 2023 Global Health Catalyst Summit. I look forward to the exciting developments and collaborations that will emerge from this year's program. Good luck to everyone. Enjoy the conference and enjoy the beautiful weather. Thank you.
I just want to say a few words about Penn Global and how they have factored in for my journey through global health. Like Jim Metz had mentioned in the beginning, he came back from Tanzania and kind of sparked my interest. And as that grew, I talked to Penn Global about some funding opportunities. And I think the really nice thing about Penn Global is that for most of us, didn't really know anything about global health. We knew we wanted to do something. We wanted to help, but what exactly do you do and how do you do it? And so as we try to formulate some ideas, we said we wanted to do like a course of quality assurance, and they really work with us to really help us narrow down and focus exactly what it is that we want to do. Exactly how do you talk to the ministers of health, and how do you interact with some of the leadership there? And so I think they have been very vital as part of my journey and other students and other faculty, because global health is still a black box for a lot of people. Like I said, you have the passion, the urge to help and do good, but it's not that simple. There are a lot of moving pieces. There are a lot of parts. I'm still learning. I think the more I learn, the more I find out I really don't know that much. But it's building that network. Building the partners, the collaborations, and then you find out that first of all, you cannot do it alone. You have to have partners. This problem is just too big for one institution, for one faculty member, for one group. I think collaboration is the only way that we can really address and solve some of the issues and problems that we're facing, and it's continuing to be like a growing issue also. So again, Amy Gass said, I just want to thank her and Penn Global and for all they've done in helping us shape, and also Glenn Galton and the Center for Global Health to really give us some guidance and some advice on grant applications again, and also kind of making our thoughts, our dreams, our vision a reality. So next we would like to show a video, welcome from the mayor of Philadelphia, and I think we will lower the lights and we will show that video.
Good morning, everyone. It's a pleasure to welcome you here today for the Global Health Catalyst Summit. In my time as mayor of Philadelphia, I have learned that the strongest solutions are the ones that involve a wide lens and a collaborative approach. There is no one person or one path that can bring an answer to the difficult questions we face in today's world. When it comes to the theme of this year's summit, Cancer Moonshot 2.0, win-win collaborations to extend the cancer moonshot globally, it will take all of us, local and federal agencies and departments, private companies, healthcare providers, patient groups, and philanthropies to make a difference. That is why this summit is so important. Every incredible achievement in the world of medicine was achieved through collaboration. There is a path to ending cancer, and we'll continue our steps down this path today. I look forward to what this summit will achieve, and I'm grateful for your dedication. Thank you and good luck.
So before we go into the next session, I did want to invite the founder and creator of the Global Health Catalyst just to give a little bit of the background, and then from there we will move into the next session. So.
Good morning. I just want to really support what Stephen said, to welcome everybody today. And I want to especially acknowledge a couple of people, the ambassadors who are with us today, the ambassador of Niger and the ambassador of Ethiopia who are sitting over there. Let's welcome them, please. We are going to have a number of other ambassadors joining us as well. Like Stephen mentioned, the key thing at this summit is really about collaboration. So usually when we start the conference, we actually say, look to the person on your right and left and say, let's collaborate. So people are going to come and go, during the sessions, but, we really want to encourage that kind of interaction. From the funding that we got from NIH, the key thing that we have to report to the NIH is say, after this event, how many collaborations did you create? Yes, so it means that, all of us should be looking to collaborate. And it's really like a conference like no other one. It's not just oncology, even though it's focused on cancer, it's not just cancer people talking. You can have the president sitting together with the kindergarten student, and the question is, can we find a way to collaborate? Actually, if you spend enough time with people, you can find out there are ways to work together. So that's a unique thing that we just want to emphasize, as we, as you participate in the conference, think about that. We also want to give a special welcome to those who are joining online. There are a lot of people who are joining us online as well, and especially for the young catalyst, there's a lot of young people with us who are really, driving this towards the future. So we want to really hope that you have a great event. Right now, we have a small number of changes on the program. So we actually are going to, we had the First Lady of Dr. Jill Biden will not be able to join us today. But we are going to move to the next session where we're going to have Professor David Collingridge to come up and will be the chair of that session. We also would like to mention that really exciting development that we have today is that today actually we're very close to the launch, to the anniversary of the launch of the Lancet Commission for Sub-Saharan Africa, which we did in May 10th last year in Ghana. And so we're going to have a small presentation about what has happened until now. So really looking forward to the next session. I'd like to welcome my friend David, please, to the podium. David, I don't know what to say, because David has actually, with the Lancet Commission, I don't know what the vision that started the Lancet Commission for Sub-Saharan Africa, but it's just kind of really started something, a big movement. It's really shined the spotlight on Africa that, we never could imagine. And, it's just started a lot of things. And I really just want to thank you, David, for that vision. Let's welcome David.
Well, good morning, everyone. It's a pleasure to be here. Dear distinguished guests and colleagues, last year, the Lancet Oncology published a commission on cancer control in sub-Saharan Africa that you've just heard briefly there from Will. The commission has emphasised several actions that need to be prioritised as a matter of urgency in that report. These included establishing and maintaining robust cancer registries, creating effective cancer control plans, incorporating cancer care into universal healthcare, early cancer screening and prevention, incorporating palliative care into the care network, building and training the oncology workforce, boosting cancer research, and increasing the use of telemedicine and innovative technologies. Now, many of those actions not only overlap the ambitions and the needs of oncology in Africa, but also the ambitions of any cancer moonshot. And like many facets of global oncology, these are bidirectional. Investment and help on the African continent from those countries that are able to do so can greatly benefit the diaspora in the donor country and beyond. The burden of non-communicable diseases, especially cancer, is fast becoming the primary cause of premature death worldwide, irrespective of the development status of the country. And this is because lifestyle and behavioural changes are shifting. A shift towards an ageing population, etiologies linked to globalisation, genetics, infection, and the environment. But also increasingly, most health systems everywhere are increasingly fragile. And collectively, these are all important determinants of health. Now, the Lancet Oncology had the great privilege of collaborating with the White House under President Obama's administration on the first moonshot. And we proposed a plan of research actions for the US, building on the Blue Ribbon Panel report out of the NCI. That commission, co-led by Professor Jaffe, who unfortunately is unable to join us today, was launched at the UN headquarters in New York with the then Vice President Biden. Now, upon inauguration of the now President Biden, the leads of this prior commission published a commentary with us calling for a reboot and a reiteration of that first commission, but focused on the things that really matter today. And that reboot of the moonshot offers a tremendous opportunity. Under the leadership of Professor Welungwa, Miriam Mutabi, who's in the audience, Cynthia Villarreal-Gaza, Professor Riechak, who's in the audience too, and Pat Laura, the Lancet Moonshot 2.0 Commission will focus on partnerships between the USA and Africa and the USA and Latin America. The goals of this commission will be to define the scale of the deficit of the cancer workforce, probably the biggest pressing need that we've ever encountered. To identify the best practices and gaps in care delivery that can be filled through innovations in research, education, partnerships, data management, and funding. To provide moonshot solutions to deliver effective, safe, efficient, and equitable cancer care at the point of need, and to define a return on investment for citizens in Africa, in Latin America, and for the diaspora from both regions who live here in the US. Now, although each African and Latin American country will need to adapt the recommendations from this report when it's eventually published to best suit their own specific needs and requirements, with strong coordinated partnerships, both within and between countries, alongside US collaborators and stakeholders, a moonshot plan that actually also incorporates some aspects of ground shot, which I won't go into today, but it's the counterpart to moonshot, can really make a difference. So returning to, as said, it's 12 months on from the first commission on cancer care in sub-Saharan Africa. The commissioners in that report made a remark which I think resonates, and it's a remark I mentioned a lot last year when we were traveling around promoting and launching that commission. But I think it really resonates through the Moonshot Initiative. And that quote is, "We've seen too many reports, too many words, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking collective action." This week's Global Health Catalyst Summit provides the perfect opportunity to have those powerful conversations needed to address the challenges that I've just mentioned. So I thank you all for coming, and we've got a great program set out ahead of us today. So I think I'll introduce Will, Professor Mutabi, to speak a little bit about the Commission.
All right, I'm going to welcome the commissioners for the Lancet Oncology Commission for Sub-Saharan Africa. My sister Beatrice, please come up. If you have not been part of the launch before, Miriam, it's the first time because of all the travel, but everybody who is part of the commission, please come up to the front. Where's Stephen? You should come, yeah. Yeah, so I should actually, this is the, I should move to the. So, can we go to the slides, please? I need to show it here too. So while we're setting up the slides, I just want to really appreciate, like David said, the fact that we've been able to, almost, it was actually 2 days ago when I was talking to Beatrice that we realized that it was May 10th, 2022, that we launched this commission in Ghana with the First Lady of Ghana. And, okay. Yes, so we launched this to the First Lady of Ghana, and then what was so remarkable, I think, if you look at some of these pictures, was that sometimes you do this document, this policy document, and it just sounds all theoretical. But the launch event, which was hosted by Beatrice, really did a fantastic job where, we were able to go and visit the cultural leaders, the king in Ghana. We were able to see cancer patients who are really, being impacted. What the reason why we're doing this commission. And that was really, really powerful. And so we're going to talk a little bit about this commission and where we are, about 1 year after. So one of the key things that this commission found was that cancer has become a major emergency in sub-Saharan Africa. One of the key things that we have had to fight competing priorities. You have HIV/AIDS, you have malaria, but guess what? People are living longer now, and it means that these things like cancer, one of the risk factors is living long. So now these are showing up, and the question is, what do we do with that? So we found from this commission that by 2030 we'll have about 1 million deaths per year in Africa. That's staggering. It's more than COVID, right? We talked about COVID, how COVID is, the impact of that. So it was really an emergency that needs to be addressed. And so we're very happy that after this, we launched this in Ghana, we launched that in Tanzania, we did that in Nigeria, we did that in many countries, and the response was really, really major. We had policymakers who were saying, we need to change something. But I want to show some of these slides, some of this data again. So if you look at cancer in sub-Saharan Africa, we see that one of the leading cancers in incidence is breast cancer. So it's really, we must do more for women. The two cancers that are leading are breast cancer and cervical cancer. Cervical cancer is big partly because of the fact that, HIV/AIDS, now people are surviving from HIV/AIDS, and one of the risk factors is the virus, itself can create cervical cancer. But this is utterly preventable. We can eliminate cervical cancer. So that's something that we really need to address. Is we shouldn't be having that as the leading cause of death. So the next finding was really that cervical cancer is a leading cause of death right now in sub-Saharan Africa. So it's a women's equity issue. So for those who, that's really something. And women are the engine of Africa, right? The economy and everything. So we really have to do something about that. Another finding we found was that by 2050, Africa would have the highest burden of childhood cancers. So again, really something that we can't let our kids, if you think about the United States, when you're diagnosed, 4 out of 5 kids would survive, whereas in Africa, sub-Saharan Africa, 1 out of 5. That's unacceptable. You really have to address that. One thing we also found out, and this happened when we launched the Lancet Commission in Nigeria, was that it's not just a healthcare issue, it's also an economic issue. So if you look at the data, so one of the things that when we did the launch in Nigeria, the headline news was not how many cancer patients are dying. One of the key things that the newspapers published was that Nigeria lost about $5.6 billion in 2019 due to cancer. And for each African country, this commission was able to make those projections. One country that we are still really looking for data is Niger. So I'm glad that the ambassador is here, and I've been talking to Fatoumata, who is also MD from Niger, that we need to get some of these more data. So these are really underestimates. The cancer situation in Africa is underestimated, and we really need to do some more work on that. But so it's not just a healthcare issue, it's an economic issue. So by addressing cancer, we can also, help with economic development. So that's why we're talking to the ministers of finance, and country that you can actually do both, can address those things. But I also want to mention the key calls to actions, just to kind of refresh everybody where we are. So we had 8 calls to actions from this Lancet Commission. And first one is, precision cancer control. So basically looking at making sure that, we are able to do cancer control planning. So most countries in Africa right now are being able to do national cancer control plans. It's really, really important. If you don't have a national cancer control plan, then you can't even address that. So that's really important to have. And the other one is making sure that we have cancer registries. That's action item 2. Designing the healthcare systems, making sure that we have health insurance, universal health insurance for all cancer patients so they can have access to treatment, increasing the cure and improving care as well. So that's really, really important. Then palliative care, actually right now, a lot of the cancer patients, Miriam and Beatrice can testify to that, present at late stage, right? So, which means that by that time, a lot of the work, what's being done is palliative in nature. So it's really important that we focus on palliative care as well. So that was one of the key calls to action. And then a big one is workforce, and I know that Professor Hedy, one of the new things for the Cancer Moonshot Commission that David just mentioned, would going to be workforce capacity building. It's really, really important. As we talk about collaborations here, if you don't have the person to collaborate with in a lower middle income country, you cannot even collaborate, right? So you have to build a workforce. So that's a really, really important one. And then secondly, we also think about innovation and research. Another action that we had was innovation and research. So that's really, really important. And then finally, one of the new ones, which obviously we did this commission all through COVID-19, so it's launched through 2020. Actually, Jennifer, you should have been here, you and Katie, but it's okay. So we did this commission over 2 years during the COVID-19. And what we saw was that obviously that was a time when we had a lot of technology. So a lot of these people, a lot of the work was done using technology. We would get on Zoom and we talk about all these things. But that's one of the major areas where we can actually leapfrog in Africa, is telehealth. We all saw that during COVID-19. And so that's something that we found that was one of the key action items from this Lancet Commission. So I'm going to talk a little bit about some of the outcomes, and then I'm going to have Beatrice talk a little bit about that, and then after that we'll hear from Miriam. So Beatrice.
Thank you, Will. Good morning, distinguished ladies and gentlemen. It's indeed an honor to be here. Exactly a year ago, we were running around like you see Professor Avery running around today, when we officially launched the Lancet Commission's report. Let me acknowledge the lead commissioners, Professor David Kerr, Professor Will Ngwa, and Beatrice Yafe Adai. I also want to thank all the commissioners, about 54, who from various institutions, countries, academicians, doctors, nurses, who came together to put up this great report under the chief editor, Professor David Corenridge, who just spoke to us. Now we lay bare the problems. It's as if we don't know. We knew, but there were problems that were fragmented. We came to the realization that it cuts across all the low and middle income countries, and especially hitting hard on Africa. So after the launch, we came to Johns Hopkins in July to launch the report again. And Dr. Laurentia posed a question that we are talking about the presence of so many reports, so many writings, and yet our people keep dying. We still have very late stage disease presentations. We still have diseases, cancers that are not yet diagnosed. We still have cancers that is, the level of stigma, the level of fear surrounding these cancers still abound. We still have a lot of cancer patients going to spend their time in the prayer camps. And so by the time they get to the hospital, their disease might have spread already, making our mortality rates very high. So what can we do? What can we do to change the narratives? We already have 8 points call to action that we needed to work on. And since July, I want to thank the team of experts who have been meeting every Sunday to come up with how we think we can change the narrative in Africa. So Professor Willingwa again, Professor Stephen Avery, Professor Salif, we have private sector representations, Mr. George Intim. We also have Mr. Eric Bryce, Dr. Laurentia Jani, and we make sure that every Sunday we convene a meeting via Zoom, and we learned this through COVID-19, that it's possible to have effective meetings. So we came up with setting up a one-stop comprehensive cancer center of excellence in Ghana. If we are able to finish this project, it's going to solve a lot of problems. Our people will not have to travel all the time abroad for treatment, and that's only for a few who can travel. What about the majority who cannot travel? We need to have a system in place, a center of excellence where we have the institutions, collaboration. It's going to touch on prevention, awareness creation, diagnostics, education, training, research, palliative care, treatment, all the state-of-the-art treatment options available. And once we have all these colleagues from Harvard, from Johns Hopkins, from UPENN, from University of Pittsburgh, from Oxford, we are sure that we can get this kind of knowledge. We know we suffer a lot of brain drain. We've spoken about this for a long time. It's not going to change today or tomorrow. So we've stopped talking about brain drain. We are now talking about brain gain and brain recirculation. So what our brother Professor Ngwa has been able to do in his invention using micro drones to send immunotherapy to the cancer cells. That is going to be done in Harvard, Johns Hopkins, UPENN. We can also do same in Africa. And they can sit in their offices here and direct the actions of our colleagues, because we are going to train more doctors, more scientists. We have the university available with all the departments so that we can come up with something comprehensive. The woman with breast cancer will not have to come for a mammogram here, go to a center 10 miles away to do a core biopsy, and to go for the report after 3 months, 6 months, and so on. A lot of our patients default treatment because of these problems. So we need to solve them and make sure that our people get the best kind of treatment that every woman with breast cancer is getting, especially in the high-income countries. We may not be able to get the same, but at least we can come closer. So I think this project, very ambitious, that we've put ahead, that we are working towards, is going to help us to reduce the cancer burden, to reduce the mortality that we have, the high mortality rates, and to save a lot of lives, and also to train more professionals in oncology. At this point, I want to say thank you for your attention, and thank you to the Global Health Catalyst that it keeps growing from strength to strength. Thank you. So please sit back, relax, and watch what we are playing.
So we're going to play a video of a breast cancer patient, basically showing why we're doing this work. So go ahead and play that, please.
Hi, everyone. My name is Benita, and thank you for giving me this privilege to share my story, and I hope my story affects someone there and also makes someone to do the needful. My mother died of breast cancer 2001 at the prime age of 39. I saw what she went through. I saw the pains she had to go through. In fact, she died on my hands. I know those dreams of you growing up, getting married, giving birth, your mother comes to take care of the children. They were all dead and gone. And life went on. Life went on. And when she died, I said in my mind that I was going to be a breast cancer advocate. I was going to tell people about cancer because I saw what she went through. I saw the pains she had to go through. I saw the stigma that was being attached to her. Then I couldn't say anything because I was just growing up. So I said I would tell people about cancer and all that. And time went on, I started growing, and I forgot everything about it. I'm a Christian. So even when you tell me to go for screening, I was like, it is not my portion. What killed my mother will not kill me. And so life went on. But 2018, I was taking my bath. And on this particular day, I wasn't thinking about cancer. I wasn't thinking about anything of such. So I just said, let me just check myself for checking sick. And I realized I felt something like a lump. My heart sank into my stomach. And I'm like, Benita, are you going to die? See how your mother died. See the pains she went through. See the agonies she had to go through. See the frustration, the depression. I was shivering. I was shivering. I didn't know what to do. And I had to summon the courage to come out from the bathhouse. I would be alone in the house. I'll be thinking about my life, about how I'm going to leave my kids, how they're going to suffer, if maybe somebody will be there to take care of them. And the fear so gripped me that I didn't know what to do anymore. I had to confide in someone who said, okay, I should just go to the hospital, Peace and Love hospitals. When I got there, And I made the doctors, they checked me, they said, yes, there is a lump there, but not all lumps are cancerous. You have to do further checkups and tests to be sure and know what it is and what treatment that will be best for you. And I did all the tests and checkups. When the results came out, I had to see Dr. Mrs. Beatrice Uyafe Adai. When she looked at the papers, she looked at me. She said, Benita, it is cancerous. You are going to start treatment immediately so you stay alive and take care of your children. Those words she said gave me hope. Those words she said took away every fear from me, and I made up my mind that, yes, cancer took my mom away, but I'm going to kill cancer. And here I am today, healed of cancer. Breast Care International has been going to the communities, to churches, to companies, to schools, to educate people on the need to present yourself early, because early detection and prompt action is the key to survival. Today I share my story because I was able to go through my treatment. But there is a woman out there. This woman is vulnerable. She is a grandmother. She is a mother. She is a sister. She is a daughter. She has just been diagnosed of cancer, and she doesn't even have money to take care of her children. How much more going to the hospital? This woman is left to her fate. Her husband has left her. Her family members have left her. I want to plead with everyone that if you can reach out to these women, I'm sure together we'll make cancer a thing of the past.
Thank you. And these are the stories that keep us going. These are the kind of stories that gives us the way forward. The fact that we need to collaborate and to change the narrative. We don't have screening systems available. So what can we do? Perhaps we can train more of our nurses, physician assistants, community-based nurses to do clinical breast examination, to educate the people, to demystify cancers, and to actually let people know that you can have cancer and still survive. We need your collaboration. Thank you.
Yeah, it's just amazing what work that Beatrice is doing in Ghana. She's one of my heroes in Ghana, and we're really happy that we can have a partner to collaborate with. So like she mentioned, this is one of the idea of the Center of Excellence, US-Ghana Center of Excellence, that's in the works right now, including with our center. It's going to be one of the outcomes of the Lancet Oncology Commission launched last year. I want to talk a little bit about a few more of those key things that have emerged. But before we do that, I would like to welcome one of the commissioners, Miriam, Dr. Miriam Mutebi, who is one of the fantastic, she is also my hero in Kenya. She works in Kenya, and she's currently the president-elect of the African Organization for Research and Training in Cancer. She led the section of one of these commissions, and we're really looking forward to hearing her speak now. Welcome.
All right. Thanks so much, everyone. My name is Miriam Mutebi, and I like to say I'm in the hope business because it's really around shifting narratives and changing the stories for our patients. And so over the next few minutes, I want to talk briefly about cancer in low and middle income countries, specifically in sub-Saharan Africa, before sort of looking at the lens of value-based care and what that means for sub-Saharan Africa, before reflecting a little, as Prof. Collingridge mentioned mentioned about Cancer Groundshot and sharing some of the ethos behind that, and really looking at strategies through the asks that we've had through the 8 items on the Commission on Lancet Commission on Cancer in Sub-Saharan Africa. We do know that the majority of, we are seeing a syndemic, as Prof. Ungwa mentioned, where we're having not only the increase in infectious diseases like the recent pandemic, but also having an increase in non-communicable diseases and cancers. The Lancet Commission showed that our incidence of cancers actually increased in Sub-Saharan Africa by 30 over the by almost double over the last 30 years. But then really thinking about it as a question of equity, where we know that only 5% of the global cancer resources are spent in low and middle income countries. We do know our patient profile, as Prof. Ungwa has mentioned. We do tend to see our patients tend to be 10 to 15 years younger than their counterparts in the West. But what is most telling is that not only are they diagnosed with advanced disease, they frequently do not complete their care. And if we do a deeper dive into the reasons behind this, we see a constellation of factors, which include the fact that patients are having to pay out of pocket in order for them to access their care, resulting in financial toxicity and catastrophic health expenditure. This is further compounded by, I would say, dysfunctional health systems, where we do know on average that patients are going to see 4 to 6 healthcare providers before definitive diagnosis of their cancer is made in Sub-Saharan Africa, really begging the need for us to educate and expand the workforce. If we do think about this, this is further compounded by social-cultural barriers that exist, especially around, Dr. Wiafe has talked about stigma, the fact that we sometimes have use of alternative therapies or collectivism. We say as Africans, our biggest strength is our strength of community, but where that sort of starts to impinge on autonomy of patients is really a cause for alarm. And it's important to look at all these strategies through the lens of value-based care, because what we do know is that it doesn't matter where you are in the world. The cancer diagnosis is complex and treatments are costly. But then how do we provide quality care without necessarily breaking the bank? And what are the methods and strategies that we use to ensure that care continues at a reasonable level of quality, but what are the ethics behind this? And so we've tried to define over the years a couple of strategies, really looking at ESMO and ASCO clinical benefit measures. We've had WHO best buys, things like Choosing Wisely Africa, that try to look at giving you a series of harmful practices to avoid that result in financial toxicity, and really basing harmonized guidelines to look at how do we consolidate or how do we homogenize care irrespective of where you were in the world, in low and middle income countries. But then this also has to be put in the context of we are in the fastest growing economies. However, we still have the highest health worker deficits, not just in oncology, perhaps more marked in oncology. But then how do we then, marry the two strategies around moonshot aspirations? And so the Cancer Groundshot is really a call to arms about pragmatic thinking. And this is based on really a simple principle. I understand Frank Sonderberg is an author who's listed as one of the top 100 thinkers in America. I don't know how true that is, but really his ethos is thinking about reaching for the stars but remaining grounded. This really needs to be the underpinnings of our approaches to care. And so if we look at what is the actual tenets, we're talking about how do we use groundshot principles? How do we ensure that we use this as a framework to launch the Cancer Moonshot Initiative? And it's really rooted in the tenets of equity, with looking at what are the prioritizations in global cancer. And for this to happen, all the basics need to be in place. We do know that the basics of treatment and what ultimately make a difference is access to both surgery, radiotherapy, and chemotherapy. And this, more than others, actually makes a difference in improving patient outcomes. So it's really ensuring that we have access to interventions that have already been proven to work before focusing on more novel or innovative strategies. In thinking about responses that are region specific. We do know, as Prof. Ungwa mentioned, that many of our patients are diagnosed with advanced disease, and it stands to reason that one of the strategies has to be around improving our palliative and supportive care. And so in recognition of this, I would say it's taken us a greater part of 10 years in Kenya, but over the pandemic period, sorry, my slides keep jumping. Over the pandemic period, we are pleased to actually launch our palliative care policy, which really tries to recognize the importance of supportive care, but again, recognizing the fact that leadership is necessary, funding and human resources are critically important, and perhaps modifying the role of, or expanding the workforce around providing palliative care services. There's also an expanding role for healthcare providers. Keep in mind, we've said that primary healthcare providers are the gatekeepers to care, and unless we can figure out a way in order for them to have the knowledge to have a timely diagnosis and rapid referral of patients within the health system. As an oncologist, you have to wear many hats in low and middle income countries. You're frequently the leader, you're frequently the opinion maker, and so we find that there's an expanding role for the oncologist and the healthcare providers in providing this fundamental advocacy, either at a grassroots level, as Dr. Wiafe is doing to an excellent level, or to policymakers, and as Prof. Ungwa says, speaking to the policymakers in the language that they understand. We do know, and over the pandemic, we have seen an increase in our use of innovations, which is one of the asks around the Lancet Commission. But it's also really looking at ensuring that this doesn't necessarily increase disparities. If I don't have a smartphone, if I don't have access to a data plan, how does that necessarily improve my care? It's all very well to be able to sit in a different country and transmit this technology, but if I can't download it and work offline, what does that actually mean? And so it's really looking at what is the stakeholder engagement, how are the systems built to actually facilitate these innovations in telehealth and greatly amplify or help to modify the gaps. One of the areas that we recognize, especially in the Lancet Commission, was really the paucity of data around research and the recognition that data is the one thing that will help to drive change and inform our interventions. So we undertook a subsequent bibliometric analysis where we looked at roughly about 24,000 papers over a 12-year period. And what we saw in terms of our cancer research output was that cancer research in Africa only formed about 8% of all research. And these are exponential figures, really showing that cancer research is really way down there. However, of course, we have seen an increase over the last couple of years. However, what should really push us forward is that if we look at the collective global output, the continental output, we notice that only out of the 49% of countries comprise 14% of all African papers, and five North African countries actually have the bulk of research publications. So really showing that there's a dearth and an opportunity rather for us to look at what is happening in our populations. How do we collaborate in order to ensure that all our patients are represented? I think fundamental to this is, irrespective of these strategies, we do know that it's important to have the patient at the center of all these initiatives, and whether it's looking at shared decision-making, whether it's looking at comprehension of patients' understanding and comprehension of the treatments and the disease process, and for want of a better word, not making the treatment worse than the disease, it really needs for us to think about how do we develop multidisciplinary approaches to care, how do we ensure that the patients remain central to this, and how do we ensure that the patient's voice resonates all through. I think in summary, I would say, even as we start to think about universal health coverage, we do need to view it through a value-based lens. Technologies, innovations, telehealth are all very good, but they're not a panacea for a dysfunctional system. So it's really about system strengthening. How do we build the workforce? How do we build the infrastructure to help support our various initiatives? And then really looking at the expanding role for oncologists in low and middle income countries, and really thinking about ground shot strategies. How do we ensure that the basics are in place in order for us to deliver effective care, which we can then amplify to the ground shot level. And I think over the pandemic, we've seen the increasing connectedness, and we're now, I would say, more of a global community. So it's really thinking about how we can collectively work together in order to ensure that patients, irrespective of where they are do receive timely access to care. Just once again to thank you for your attention in acknowledgement that it does take a village. I think the key theme behind this meeting has really been around collaboration. So it's really looking at how do we work together? How do we get all the moving parts in order to ensure better care for our patients? Thank you.
Thank you very much, Miriam. So we're going to actually give a chance if somebody has a question for Miriam before we move to the outcomes of this commission. Is anybody has a question? Because it's a really important talk. We never get Miriam here every day. So please give a chance for questions. Anybody? Okay, good. Is there a microphone for? Yes.
Yes, thank you for this really impressive explanation and presentation, Miriam. And I have a question. Myself, I'm involved as well in such prevention programs in different settings in Africa. I'm coming from the sexual reproductive health and international global health background. And I'm the board member of directors for Rotary International and native from Germany. So far, the case is what you have been mentioned as well with palliative care, which is quite a new and very challenges issue for African settings in sub-Sahara zone. We have as well a program which colleagues from my side started as well in Ghana and other countries as well in Ethiopia. So far, how you are achieving it? How are your major goal? How are your inputs? How you are targeting your beneficiaries, and how is the work with all the stakeholders? Why it's a very holistically huge approach, and it's very ambitious, and I really admire what you are doing and how you are achieving it. Perhaps you can precise this a bit more. Thank you so much.
Oh, okay. I'll just answer. Thank you. I thought there was somebody who were going to take a couple of questions. Yes. In response to the question, it is definitely very ambitious, and I think the key components to this are really around collaboration. And it's thinking through what are the different moving parts that one needs in order to ensure service delivery. And so for us in Kenya, for instance, it was looking at how do we, simple thing like palliative care access to opiates. The laws are in place such that it's only, for instance, doctors who can write a prescription. There's misunderstandings around healthcare providers who don't necessarily want to prescribe opiates because they believe patients are going to get addicted. So it's all those different moving parts. And so looking at how do we, one, educate, empower the workforce. So right now we're having central reconstitution of opiates, oral morphine, and then distributing those to palliative care centers around the country. It's looking at how do we deliver this care closer to the individuals. So it's all very well if the morphine's, in Nairobi, which is 400 kilometers away, how does it get to this, Fatima or Mary in the ground who really needs it? And so it's decentralizing those palliative services, and again, also expanding the role of our oncology nurses and our nursing care practitioners in order to be able to safely give chemotherapy. But I think really the political goodwill, as we've seen in many countries, is invariable. And it's really about how do you speak to policymakers in the language that they understand. As clinicians, we all, carry our patients' journeys on our sleeves, but it's really about how do we break that down into concrete numbers, whether it's the economics of loss or the benefits of investing in earlier diagnosis. Thanks.
Oh, one more question. Yeah.
My name is Twali Ngoma from Tanzania. Thank you very much for the presentations on this commission, and I thank David very much for giving us in Africa this opportunity. Today, we are here talking about 1 year after launch. I was just thinking, what's going to happen 10 years after the launch? Do we have any way of a measurement or anything like that that we can monitor and evaluate after that? A very good report which needs implementation, which needs a strategy, which needs to have also indicators and outcomes if we are to be serious about it. Is there any way we can think about making this report valuable to us, in that in 10 years we could sit down and look at what we had expected, what we have been planning, and during the 10 years also be able to monitor and make changes wherever there is. We have been talking about a center of excellence in Ghana, a very good idea, and we can talk about other things, but we need to have it structured so that at least we can, all of us can follow it up. And is there any new money? Is there a way of raising new money for this? Because with all this, good intentions, funding is needed. We need funds. There is no way you can do cancer control without funding. Are we having any plan of raising new money so that, because most of the things are doable. And I work in Africa, although most people say funding, even if it's available, it may not do as much as one would want, but I can assure you, there is no way you can do anything without funding. Political commitment, political will, trained workforce, but at the end of that, funding will be needed. Is there any way we can plan for funding so that we can implement this commission report? Thank you.
Thanks, Prof. Twaleb, for those excellent comments and reflections on what one would say what we foresee as the opportunities ahead. And I think you did mention a couple of key features which are really around funding. And I think one of the things that we do need to think critically about is how do we collectively as a global community hold our policymakers accountable, because it doesn't matter what source of, whether it's crowdfunding or sourcing, unless your governments are investing in the health systems, which we know for many countries in sub-Saharan Africa, we have less than 5% of our GDP being committed to health, not just oncology. So it's really about how do we as a collective community amplify and really speak to policymakers in the language that they understand. And I think that's going to be critical to any sort of sustainable or strategy that has longevity. The second point is, how do we sort of think beyond the afterlife of the commission, and how do we sort of think about 10 years in, 20 years in? What are the strategies or what are the indicators that one could employ in order to achieve these gains? We've had about centers of excellence. And I think this is my moment to sort of plug in the African Organization for Research and Training in Cancer, which is really the primary body on the continent that's really trying to look at how do we help to amplify some of these strategies. And whether it's through research, so that we know what's happening in Ghana, we know what's happening in Tanzania, we know what's happening in Kenya, we know what's happening in South Africa. How do we coordinate efforts, and how do we use those opportunities for shared, I would say, for knowledge sharing and for decision making, looking at what works in West Africa? Can we employ some of these strategies? I think are the way to go. In terms of the additional sources for funding, I'm going to ask Prof. Ungwa, who's been really on the circuit trying to raise funds, to perhaps give his 2 cents. Thank you.
Thank you very much, Miriam. Yeah, I think those are really important questions in terms of the funding. And I think actually one of the things I wanted to highlight a few more of the things that have come out from that commission to your question, Professor Ngoma, working with collaboration with the White House in December, the US-Africa Summit's Leaders Conference. And we're glad that Catherine Young from the White House is here. They've done a lot of work with leading with the First Lady, Jill Biden, in trying to mobilize funding. And that really, some of that built on this Lancet Oncology Commission for Sub-Saharan Africa. It's really kind of a combination with the Cancer Moonshot. And already there's been significant amount of commitments done. I'm going to highlight a few of those in a couple of slides next. So, but before we do that, I just want to, let's thank Miriam again for a wonderful presentation. Thank you, Miriam. And then I would like actually to give a chance to David to answer the other part of the question for Twalib asked about how do you normally measure the impact of your commissions? And then I will talk about what we've done so far. Do you mind doing that, David? You can, yeah.
That's a really good question. Give me a hard question the first thing in the morning. We have a number of indicators in-house that we look at in terms of the impact of these commissions. We're obviously looking at projects that have been formed. We're looking at the social impact of these commissions. And we actually have a project ongoing right now within the Lancet where we're looking at what are those social impact indicators. We've got a list of, we're working through about 168 indicators at this time that we want to boil down into a single metric of value. And that metric of value, we're looking at the moment 8 nodes, if you like. How do you define value? And we've boiled this down to about 8 nodes. And we think we can create a metric, a bit like a spider web, where you measure each node on a scale, say 1 to 5. And you plot this as a web. And you can compare that then to the wider world on the same issues and just do that comparison of how this organization is doing versus that organization, or this country versus that country. So we're working on that. It's a very tricky beast. But also beyond that, we do revisit commissions. So on many of our commissions, we've done follow-ups 2 to 3 years down the line, where we take stock. So what's been achieved? What's the impact of that? Where are the gaps? What are the new issues and challenges? So we highlight those again. So there's a package of parameters that we're looking at.
Yeah. Thank you, David. I mean, it's really a big, tough questions, and I'm glad that you're already thinking about that. I think there are a number of ways that we can actually measure. I would say for sure, the Lancet Oncology Commission for Sub-Saharan Africa is already having an impact. So I'm going to highlight a couple more things. Can you move to the next slide? Yeah, so I want to show this picture. This was taken in December. We had the US-Africa Leaders Summit here in Washington, D.C. As I mentioned, through the work of the White House, First Lady's initiative, and Dr. Biden and President Biden, who reignited the Cancer Moonshot last year. And I know Catherine Young, who is from the White House, is going to talk about that a little bit. But I wanted to highlight this because this is actually really a great outcome that we're already seeing. like I mentioned, this is really kind of merging this with the Cancer Moonshot. Out of this event in December, hosted by Dr. Biden, about $360 million in commitments were made. 200 million from the U.S. government, from different parts of the U.S. government, and then about $160 million, if I remember correctly, from the private sector. And in one of the sessions after this, led by Jennifer, she's going to talk about the industry, that engagement. So I would say, for one, there is some movement already. This is a step in the right direction. It's not enough, right? But, we see that there's a lot of engagement right now, and the spotlight is on Africa. And again, that's why we thank the Lancet for making this happen. And so there is that mobilization. You're going to hear through today some of those initiatives that are actually coming out of this Lancet Commission due to that. But I want to highlight a couple of them. So we've mentioned, Beatrice has mentioned the initiative in Ghana to establish a Cancer Center of Excellence in Ghana. We also have an initiative in Tanzania. I don't know, the ambassador is not yet here, but she's been spearheading that initiative, facilitating US-Africa collaboration to set up a cancer center in Tanzania. Tualip, you are part of that initiative, so you're very aware. And this is really an important thing, to actually set up a medical tourism, so people don't have to necessarily go to India or come to the United States for their cancer care. They can go to Ghana in West Africa, they can go to Tanzania in East Africa, and so that's a really fantastic initiative that's come out. I also want to mention this multi-center clinical trial. So remember, in the calls to action, we talked about research and innovation. So one of the key things that has actually come out of this, we have a multi-center clinical trials that are going on. One of them I would like to highlight is called the Hypo Africa. You're going to hear about that tomorrow with Professor Luca Inkochi, and it's supported by BVGH. But this is a clinical trial that, just as an example of where we have collaborations, Tanzania, Nigeria, and South Africa are part of that. You're going to hear more about that tomorrow. And we also have Uganda just joined. And this is one of these things where you have an evidence-based approach we know works, but then people are not implementing it or taking it up. And you're asking, why are people not taking it up? I mean, we know interventions can eliminate cervical cancer, but why is it still there, right? So implementation research is really important. But what we've seen with this clinical trial is that we started doing something where it can halve the time that it takes for a cancer patient to come in for their treatment, which means that the time it takes for one patient, for you to treat one patient, you can actually treat two. That's a 100% increase in access, if you want to look at it that way, right? But why have we not been doing this so far, right? So then we start this clinical trial. Professor Luca presented this in Tanzania the other time, and now Uganda says, I'm here, and other countries are now interested. But you can see the fact that now that's actually one way to facilitate. It's like somebody starts something, you start a movement, and then other people want to be part of it. And so this is really one of the things we want to highlight. This is just one initiative, about good examples coming out of this. Because we also talked about education and capacity building. Since the commission was launched, there's been a lot of initiatives about, training. And like David mentioned, the new Cancer Moonshot that's been launched commission, one of the things that is going to be focused on is on capacity building. And I think that that's really, really critical. I want to mention one which Saiful asked me to make sure I mentioned, which is that enhancing the quality of care. So actually, when we started doing these multi-center clinical trials, and other people have been doing that, they realized that, you need to kind of enhance the treatment quality. And so there's a lot of initiatives right now in Nigeria, training medical physicists who are delivering radiation therapy to enhance the quality of care. It's been done also for Mali and other countries. And so this is really fantastic way to kind of, see how we can improve the quality of care also in Africa. I would like to mention the awareness one, which is really huge. Again, I've talked about, how using the launch events, there was a lot of awareness created. One of the things we found out doing this Lancet Commission was that, of all the 2,000 dialects in Africa, only very few of them actually have, some of them don't have, a lot of them don't have a word for cancer, right? So if you don't even have a word for cancer, you cannot begin to address it. And so creating this awareness, partnering with cultural leaders, kings, and others, people who are really, in touch with the population, has really had an impact. That's something that we're seeing. And so during this conference, you're going to be hearing videos from, presidents, a lot of stakeholders who are now part of this awareness campaign. And I think that's really, really important because as people get aware, and then we can think about how we can collaborate. So I am going to stop there for now, and then I'm going to call one more person, and then I'll come back to David. We have another cancer survivor who is Esther. Is Esther here? Esther Peter? Yes, please come up. So, and this is really important. We always like to kind of humanize what we are doing. So sometimes it can be just talk and theory, and but it's really nice to be able to see what the impact of what we are doing. Who are we really doing? Having an impact on. So we've watched that video from Ghana. Yes, come up, Esther. We've watched that video from Ghana, but we also want to watch a video from the United States. Not a video. We actually have Esther, sorry, who is going to speak about breast cancer in the United States. And why is that important? It's important because as we talk about the cancer moonshot, extending that globally, we want to show that it's global health is local health. So even while you're having the interventions you're developing to impact, whether it's in Africa, also can address disparities here in the United States. And so we want to make sure that we keep the patient or the survivor on, one of the calls to action or the focus of the cancer moonshot was to ensure that we improve the experience of those who are living and surviving from cancer. And so we thought it would be really nice to have Esther talk about her story. So let's welcome Esther. Let's give her a hand, please.
Thank you. Good morning, distinguished ladies and gentlemen. Thank you so much, Dr. Will, for inviting me over. I am blessed to be here, standing tall and alive. I am truly honored to have been invited to speak here today. This is really, it's really important, really dear to my heart. Exactly a year ago, precisely on February 28th of last year, 2022, I was diagnosed with stage 3 HER2 positive carcinoma of the right breast, which means stage 3 breast cancer. At that point, of course, I was a mom, devoted wife, registered nurse, nurse leader, and also completing my MBME in med school. That diagnosis put a stop to everything I was working so hard to accomplish in life. I had to pause. Sometimes you just have to pause. And that was a time for me to pause. I immediately commenced treatment. But there was something that really kept bothering me. Not even the diagnosis itself. I knew what it was. I knew it had to be taken care of. I had little kids to take care of. I had so much work to do, But what really bothered me was the fact that that cancer, was found by chance. In 2021, I was symptomatic. I had the pain, I had the lump. We all teach to self-breast examination. And I had the symptoms. I went to see my provider. I had the mastectomy done. I had the mammogram done. But the result came back weeks later, and I was told it was benign. And as an African, that I had dense breast. This is what many African women will hear. You have dense breast, fibrocystic breast changes. Now, the plan was to follow up in a year's time for a repeat mammogram. But we didn't have to wait for a year because in like 10 months, by chance, I was found to have breast cancer. Now the question is, what if I had waited for 12 months? We found it at the stage 3. What could have happened? My only concern at that time was my 4 little kids and the work that I know that I still have to do. That really touched me. We talk about people in Africa. We know there's a lot of work to be done. What about those of us here? These things get missed every day. I was fortunate. Mine was found by chance, and I commenced treatment. And I'm grateful and thankful to say today that The tumor went from a stage 3 to a stage 0. Chemo was very effective. Thank you. Of course, with the chemo being effective comes this adverse effects, right? I changed completely. Changed from who I was. My hair fell off, my skin, everything, the weight gain, everything changed. But that didn't stop me because I knew that I was allowed to go through it for a reason. Their lives out there to be touched. I'm Nigerian by birth. I just lost my brother-in-law on the 12th of April to colon cancer. Exactly what was said here a few minutes ago was exactly what happened to him. He was diagnosed. But by the time you have to do one test, one scan, one imaging, and you have to wait for weeks and months for the results, you have to travel a far distance to go complete that, or you don't even have the financial resources to do that. This young man died at 40 from colon cancer, leaving behind 4 little kids. I am fortunate to be here today, and I know there's a lot of work to be done. My chemo was effective. I ended up with a lumpectomy. Thankfully, I completed radiation in March. And of course, I completed NBME. And now I just commenced my residency in med school. I'm a living testimony. I am thankful. And this is the reason why, again, as I paused, being a nurse leader, I am now an active advocate against breast cancer. You know, I am collaborating. Dr. Will talked about collaborations. Yes, right after surgery, I ran straight to Ms. Ife Nwabuku, who is the CEO of the African Women's Cancer Awareness Association, also known as AWCAA, in Maryland. And that's where I go every day to help advocate for other patients, other survivors. And we also provide navigation services. So if there's anyone around the area that is going through what we went through, we want to make sure the experience is a little easier on them. We want to make sure that we provide the resources that are needed. There's a lot of work that needs to be done. Thank you.
Thank you so much, Esther. We definitely are so proud of you that you're going to med school. That's amazing. We're cheering for you. That's wonderful. You're returning that. That's a really good example for us to follow. So at this point, we're going to hear some remarks from the First Lady of Ghana, who couldn't be with us.
Hello, everyone. It is a pleasure to join you all today. Thank you for the invitation to speak at this very important summit. I commend the organizers of the Global Health Catalyst Summit and the Lancet Oncology for putting this summit together. I'm sorry I could not be with you there physically, but let me state that I was extremely honored to have been part of the first launch of the Lancet Commission in Africa in Ghana in May. Congratulations to the Lancet Commission, Prof. Will Ngwa, Prof. David Kerr, and our very own Dr. Beatrice Adai, whose efforts have been highlighted in the Commission as a model for emulation. As First Lady, I've been deeply involved in the fight against cancer in Ghana. We have made some significant progress with the development of a national cancer strategy. We are building a comprehensive cancer registry and have recently increased the number of treatment centers. Through my advocacy, our National Health Insurance Scheme now covers 4 childhood cancers, namely Burkitt lymphoma, acute lymphoblastic leukemia, Wilms tumor, and retinoblastoma. These make up about 60% of childhood cancer cases in Ghana. My foundation has also built a 54-bed hostel in Kolebu Teaching Hospital for children with cancer and their parents to keep them in close proximity to treatments. Nevertheless, we still face challenges with infrastructure, diagnosis, specialized healthcare professionals, access to cancer therapies, and the prohibitive cost of cancer care. This narrative has to change, particularly given the alarming cancer statistics in Africa compared to the developed world. I'm therefore committed to doing all I can to mobilize more efforts to lead the fight in Ghana. Indeed, I'm happy to announce that on the 16th of June 2022, together with other members of the Africa First Lady Space Mission, we had a meeting with the International Atomic Energy Agency on the Ray of Hope initiative. This seeks to support member countries in the diagnosis and treatment of cancer using radiation medicine. I want to say that the fight against cancer is a top priority for the current government, and we are keen to remove barriers to access and willing to work with partners to ensure improved access. I'm certain that together with all stakeholders, we shall make great strides in improving care and alleviate the suffering caused by cancer. Thank you to the USA government's National Institutes of Health for supporting this event. We hope we can count on President Biden's Cancer Moonshot initiative in the fight against cancer. I also welcome USA and other international stakeholders to join Ghana to fight cancer. As the African saying goes, if we work together, we can go further in having a bigger impact. God bless us all.
Yeah, that's one of the, we're so proud of the First Lady of Ghana. She's one of those who has been really in active fight in collaborating against, since we launched this commission, and really having an impact in their country of Ghana, and the other First Ladies as well. So really thankful. So now we are going to invite another First Lady who is from Nigeria, from Kebbi State in Nigeria, a remarkable, wonderful First Lady of that state. Dr. Zainab Bakudu, Her Excellency. She is going to, she actually is the president of the foundation, of Medicaid Foundation in Nigeria as well. I'm going to welcome her to make some remarks as well. Let's clap for her, please.
Good morning, everyone. I see a lot of familiar faces. It's a pleasure to be here, and I thank you for the invitation, and congratulations to this Global Health community for the work that they're doing. My name is Zainab Shankafi Bagudu. I'm a pediatrician. I trained as one in the UK and went back home to Nigeria and got pulled into cancer advocacy. This gave me the opportunity to view through both lenses of how cancer is in a high-income country and also a low-income country. We started the Medicaid Cancer Foundation, initially creating awareness, screening, and fundraising for cancer patients. And this also allowed me to see the problems that exist, the depth of a lot of the things that have been spoken about here today, very eloquently put together in the Lancet Commission as well by my sisters Beatrice and Miriam, who live this world in their doctors' offices. Going further, my husband became the governor of Kebbi State, which is one of the smaller states in northwest Nigeria. And my lenses, my dual lenses again came into view. I had the opportunity of working alongside government policymakers to try to view and see how things are from that end, having seen it from the end of a doctor and the patients. It's not as easy as we think, I'm sure we all know that, but I have a few learning points that I would like to share. We must, as clinicians, as scientists, as advocates, include government more when we have our commissions, our events, our programs, and not just government or at the ministerial level. We have to talk to the legislators, we have to talk to the finance directors, so that all these people, all our aims and goals that we're trying to achieve can be worked at from the ground shot, as we keep talking about. We do have a lot of reports, and implementation is a problem for us, but I don't think they're enough. I don't think they're too much, and we must continue to make these reports. We've seen the effect that it has. The Lancet Commission, for instance, has galvanized all this action as well as funding. So by involving the scientists and talking to the government, we've been able to mobilize a lot more resources than we had 2 years ago for cancer in Africa. So this is a step forward. But a key component that we have worked with in Kebbi are the legislators. And they have been able to appropriate not just funding, but also create policies that will enable us to keep our trained staff in-house, in country, to help to improve the conditions of living that makes these people go away to high-income countries and so on. So there's a lot to be learned from those kind of experiences. I think that the work that the Global Health Catalyst organization is doing is very commendable. Today, as I drove here in the taxi that brought me here, of course, chatting as usual, he said, "You're from Nigeria, a very rich country. Everybody says this first." And then he laughed, and I knew what was coming. Rich, but problems. Yes, we have problems, but I think that the problems that people face in Nigeria, I know for a fact, is that we're not engaging the right people. We've heard so much about the aims and the need to have partnerships and talk to each other at this summit and engage each other. But are we going to engage the right people? Are we going to talk to the oil drillers in Nigeria? No. We should find the right people, and I'm offering myself as an ambassador of cancer control for Nigeria, and I hope that you will count us as one of the right people to talk to, because we know the terrain. Sometimes it's about knowing how things work, how it operates in your environment, and that way you can make it work much better. I do admire, and I must say, I admire very greatly the work that is being done in Ghana at all levels. There's a connection between the government, the scientists, and the advocates, and this must have happened over time. Nigeria is a much bigger country, it's much more complex, but we're able to astride all these institutions and come together so that these things work. So once more, I congratulate you. I congratulate all the commissioners of the commission. Will, thank you for the perseverance and the invitation, and I look forward to doing a lot more with you and indeed all your colleagues. Thank you so much.
Yeah, she's really wonderful. We really should not take things like what she just said lightly, right? She's offering herself as an ambassador. Come on, let's clap for her once more, please. We're definitely going to take you up on that offer, you know. So Nigeria is definitely 1/5 of Africa. Like, so if you can have an impact in Nigeria, that's huge, right? So, so now we are going to go to the second most populated country in Africa, I think, Ethiopia. Yes. So we are going to have a chance. We had the Honorable Minister of Health, Dr. Leah Tadis, who unfortunately cannot be with us, but we have the ambassador who is here with us, and we are also going to listen to her recorded remarks. Please go ahead.
Greetings, everyone. First, I would like to thank the organizers for inviting me to speak at this Global Health Catalyst Summit, which is an important platform for catalyzing collaborations to advance global health equity. I was hoping to attend in person, but unfortunately, I couldn't make it because of other commitments. I would like to acknowledge the presence of His Excellency Ambassador Dr. Sleshi Bakala, Ethiopia's ambassador to the United States, directors of the Global Health Summit, Dr. Swils, Enwa, Stephen Avery, and Saiful Haq. It's also my privilege to thank Dr. Akila Viswanathan, Director of Radiation Oncology and Molecular Radiation Sciences, and Bethlehem Floreza, Dosimetry Supervisor and Senior Clinical Dosimetrist at Johns Hopkins University. According to Lancet Oncology Commission for Sub-Saharan Africa, cancer is growing significantly in Africa. It accounts for about 6% of all diseases from non-communicable diseases and is a major public health challenge in Ethiopia. Every year, about 77,500 new cancer cases are registered in Ethiopia, and sadly, only 15% of cancer patients have access to the appropriate care and treatment. In Ethiopia, breast cancer accounts for a third of all cancer types, followed by cervical cancer, which accounts for about 14%. And notably, close to 65% of all types of cancers disproportionately occur among women. And 65 to 70% of cancer patients visit care at a very late stage, resulting in poor treatment outcomes. Poor public as well as providers' awareness, low access to care, and scarce availability of trained cancer healthcare workforce are among the reasons for late presentations. Ethiopia has taken significant strides to address the cancer care gap. A national cancer control strategy has been developed focusing on a continuum of care approach from primary prevention to early detection, diagnosis and treatment, and palliative care. The main implementation milestones include expanding cancer radiotherapy treatment centers from only one for many decades to 7 centers, of which 3 are already operational in the country. And we've also scaled up chemotherapy services to 17 hospitals. Additionally, investing in human resources for cancer care has resulted in increasing the number of hemato-oncologists from only 3 to 4 to currently over 30, plus also over 40 residents who are currently in specialty training. Furthermore, Ethiopia has successfully implemented community-level screening with visual inspection of acetic acid for cervical cancer at unprecedented scale, with over 1,200 public health facilities now providing screening to close to 1 million women aged 30 to 49. And these are combined with over 1,500 cryotherapy and about 300 lip machines available. Public awareness creation has also been a crucial component of cancer control in Ethiopia, using the primary care system. But despite these progresses, we have significant challenges. One is a need for training of specialized cadres of health workforce, such as radiotherapists and medical physicists, which is far behind the pace. Additionally, there is a need to improve radiation treatment, equipment maintenance capacity, which requires more biomedical engineers trained and made capable of troubleshooting advanced machines. Advancing the health system to respond to the complex needs of cancer care is also crucial, and this includes the effective supply chain management of cancer medicines and commodities, data capturing, digitization to enhance skill transfer across various levels of care, including the use of telemedicine. And data for cancer is also a significant gap in Ethiopia. Our country does not have a well-established cancer registry system, which is crucial for monitoring and evaluating the effectiveness of cancer control strategies. Diagnostic capacities for targeted treatment and advanced pathology investigation, such as nuclear medicine, PET scan, and mammograms, are suboptimal in the country. These gaps in cancer care in Ethiopia highlight the need for continued and concerted efforts to improve the care and the outcomes. As I mentioned earlier, one of the critical areas is capacity building of human resource, which I hope is a focus of the summit, with priority training areas being radiotherapy technologists, radiation oncologists, medical physicists, pediatric oncologists, hemato-oncologists, oncology nurses, nuclear medicine physicians, radiopharmacists, nuclear medicine physicists, and nuclear medicine imaging technologists. And preventive maintenance capacity, as I mentioned earlier, is also a crucial area of engagement. And information technology, including cancer registry, research, and evidence generation, are also methods to improve the quality and effectiveness of cancer care in Ethiopia. Expanding chemotherapy services, strengthening diagnostic services, including imaging, molecular testing, and advanced pathology services are also crucial. So to conclude, engaging with you and other global partners in these potential areas, particularly focusing on capacity strengthening, can help improve cancer care in Ethiopia with much better outcome for our citizens, as the power of collective action and collaboration can accomplish a lot. Once again, thank you so much for this opportunity, and we look forward to a growing collaboration, and I wish you all a very productive and successful summit. I thank you.
Yeah, we really want to thank the Minister of Health for those remarks. She's really interested in collaboration, and I think there's a lot of opportunity here. There are many people who, the ambassador is here. So later on this afternoon, you get to hear from the ambassadors and engagement. If there's somebody who thinks you want to hit to that call to action to collaborate with Ethiopia, we'll have a chance to have further discussion about that this afternoon. So that's really wonderful. So now I'm going to call David, who again, we just want to really thank for providing this opportunity to spotlight on Africa, to make some closing remarks for this session. I would like to say that we'll have, a very powerful session coming after this that's going to continue on the theme of collaborations and commitments. So David, please. Yeah.
Many thanks, Will. I think it's important to thank all of the speakers this morning. I think they've all made some very powerful statements today that have shown that this commission has really been a catalyst and a drive for change. We've seen that it's engaged a lot of very powerful leaders at the highest levels of our society, highest levels of our medical society, but also government. And this is tremendous, absolutely tremendous. We've seen mobilization of a lot of resources and a lot of new partnerships that have created a lot of opportunity. But we shouldn't lose sight that we are only at the very start of this journey. There's a huge amount still to do. And really, the work starts. It should have started a few years ago, but we really have to get on with this job at hand. There is so much to be done. So I thank you all for attending this session. I hope it's inspired you to make those new partnerships here, to have those courageous conversations amongst the attendees here, but also in your communities to make that change. So the time for action is now. So thank you again. I think we're going to take a little break for coffee, but thanks for attending this session. Thanks.
Sound the way I planned. Test 1, 2, 2, 1. Q&A mic 1, 2. Okay. How's that? Better? Better level? 1, 2. 2, 1.
Test, test.
All right, test 1, 2. How's that? 1, 2. Okay. All right, awesome.
why am I soft in the middle now? Why am I soft in the middle? The rest of my life is so hard. I need a photo opportunity. I want a shot at redemption. Don't want to end up a cartoon in a cartoon graveyard. Bone digger, dogs in the moonlight. Far away, my well-lit door. Mr. Beer Melly, get these mutts away from me, you know. I don't find this stuff amusing anymore. If you'll be my bodyguard, I can be your long-lost pal. I can call you Betty, and Betty, when you call me, you can call me out. A man walks down the street, he says, why am I short of attention? Got a short little span of attention, and whoa, my nights are so long. Where's my wife and family? What if I die here? Who'll be my role model now that my role model is gone? You duck back down the alley with some roly-poly little bat-faced girl. All along, there were incidents and accidents, there were hints and allegations. If you'll be my bodyguard, I can be your long-lost pal. I can call you Betty, and Betty, when you call me, you can call me out, call me out.
Closer behind.
think of you, I always catch my breath, and I'm still standing here, and you're mine.
All right, ladies and gentlemen, let's be seated, please. We're about to start. Let's be seated, please. Yeah. So we're going to start the next session, really important section, just kind of building on what we just ended, engagement with industry. So one of the things that the Cancer Monitoring Office of the White House with Catherine has been doing really well is engaging, different stakeholders, which includes industry. We're also going to see later on this afternoon the diaspora and the ambassadors and all those people. So we're going to open up this session now by inviting Dr. Catherine Young from the Cancer Monitoring Office of the White House to give her remarks. Let's give her a hand, please.
Good morning, everyone. It is morning, right? Yes. Okay. Thank you. It is my pleasure to be with you all here today, and thank you, Will, so much for this opportunity to provide a few remarks with you. As you have already heard probably many times this morning, the President and First Lady did reignite the Cancer Moonshot a year ago and set two new ambitious goals. The first is to decrease the number of cancer deaths by 50% over the next 25 years. And the second, as Will mentioned earlier, is to improve the experience of people living with and surviving cancer. And to do so, they are calling on everyone to do their part, including federal agencies, private companies, healthcare providers, patient groups, philanthropies, and so much more. And it's not just here in the US, but across the globe. It's why the ambitions of the Cancer Moonshot now extend far beyond our own borders, especially as the burden of cancer falls heavily to lower and middle income countries. And looking around this room today, because I was just reflecting on the train ride up here that a year ago at the Global Health Catalyst Summit in DC was where we first publicly committed to taking the Cancer Moonshot global. Seeing all of you here, seeing so many people that we have now engaged with, sharing your progress, your ideas, your actions, sharing your time, seeing your passion and your dedication, it's a reminder of just how this community has really rallied behind the President's call to action. And it's why the Cancer Moonshot has broadened our scope internationally. And our work is to focus on equity and collaboration, again, a hot word today, thereby increasing access to prevention, screening, treatment, and care for everyone around the world facing a cancer diagnosis. And we've already made great strides. At the US Africa Leaders Summit event hosted by the President this December, the First Lady announced by the Cancer Moonshot $300 million of commitments from both the US government and from the private sector partners. These efforts, some of them you will hear from now, include strengthening the public health infrastructure, building resilient health systems, investing in health workers, as well as funding for robust and impactful initiatives across the African continent on cancer prevention, screening, treatment, and research. If there was any doubt that we can make a significant difference in the lives of cancer patients across the globe, or reach audacious goals like eliminating cervical cancer in our lifetime, then these examples of commitments that were made and that you will hear from in just a moment should put to rest any of them. Because if there's one thing that we have heard very loud and clear this past year, it is that together we can make a difference. And so I'm very excited now to welcome Jennifer Dent to the stage as we will hear from a number of these commitments and the progress they are delivering. Jennifer, over to you.
Good morning and almost afternoon. It's a real pleasure to be here again at the Global Health Catalyst Summit, and we've had a great start to this meeting. And I love the theme of our meeting this year, the Cancer Moonshot, Collaboration, Public-Private Partnerships. And this panel is going to highlight some of the examples of how the private sector is contributing to advancing the Cancer Moonshot and taking the Cancer Moonshot to Africa. So I'm going to ask all of our panelists to just file up now. And as I just speak for a moment about some of the progress and general work that we've done since the US Africa Leaders Summit in December. So as many of you know, BVGH launched the African Access Initiative in 2017 with 5 ambitious goals: to advance sustainable, demand-driven access to high quality and more affordable cancer medicines, to strengthen healthcare infrastructure, to train oncology healthcare professionals working across the cancer patient management pathway, to facilitate African-led research to fill the data gap, and to support advocacy. We've made tremendous progress since we launched AAI in 2017, but there's still much work to do. And in December of last year, President Biden hosted the US Africa Leaders Summit, where the theme during that summit was public-private partnerships and engaging with the private sector and recognizing the many contributions that the private sector could make to strengthening partnerships between the United States and Africa across sectors, including cancer control. And we heard from Dr. Catherine Young about the First Lady's, Dr. Jill Biden's commitment. And I actually witnessed that commitment when now President Biden, then Vice President Biden, hosted in 2018 the Biden Cancer Summit in Washington, D.C., to speak about launching the Cancer Moonshot at that time and really changing cancer as we know it. And at that summit, we had the opportunity to speak about cancer in Africa. I'd actually just traveled from Nigeria after meetings with the 8 regional cancer centers, cancer leaders, First Lady, Her Excellency, Dr. Zainab Bagudu, the Minister of Health, and to understand what Nigeria's priorities were in strengthening cancer control and cancer care in that country. And we've transitioned from that time in 2018 to now we have President Biden in his role and the First Lady committing to take the Cancer Moonshot to Africa. So we have tremendous momentum and support at the US government level. We have many activities and commitments and actions that are ongoing at the private sector level that we're going to hear about today. And these commitments are actually driving progress toward taking the Cancer Moonshot goals to Africa. And I think importantly, what Professor Will Ngwa, what Will is able to do with this meeting is bring together a very diverse group of leaders to bring very strong representation and leadership in cancer control, cancer leadership, policy, and treatment from representing so many different countries in Africa, people that are making such a difference, like we heard from Dr. Beatrice, Dr. Miriam this morning on the continent. So now I want to introduce some of our speakers here today. I think we'll start, we have one guest that is going to zoom in. We have Dr. Chris Reddick, who is the Vice President and Head of Research and Development, Health Equity at Takeda. Chris is going to join us by Zoom, and Chris is going to speak about some of the activities that Takeda has ongoing that are actually moving forward and making real progress in taking some US innovations, fostering research, and training oncology healthcare professionals. And just to note, Chris has been one of our collaborators and partners on the African Consortium for Cancer Clinical Trials, and I think many of you in the audience know Chris. So over to you, Chris.
All right. Thank you, Jennifer. And I also want to thank Will as well for the invitation to join this panel on such an important topic. So very good to be able to join you all today. Takeda has been a long-term and proud partner with many of you here in advancing cancer care in Africa. And we have taken a holistic approach to this. So not just focusing on one aspect of care, so whether it be clinical trials or diagnosis or treatment, we've really tried to align it with our corporate philosophy of what we call PTRB. So that's P, putting the patient first, building trust with society, reinforcing our reputation, and developing a sustainable business. So with that as our kind of guiding philosophy, we opened our first office in sub-Saharan Africa in Nairobi in 2016. And since that time, we've continued to build infrastructure and embedded this philosophy within our organization to make sure that it's sustainable. So we've now developed a Center for Health Equity and Patient Affairs. We have an Access to Medicines team that is setting up patients assistance program to provide affordability-based access in sub-Saharan Africa. And more recently, we've also implemented a diversity in clinical trials office and team that is really looking at improving the participation of underrepresented investigators as well as patients in our trials. And as Jennifer was saying, one of our big areas of focus has been partnerships on the continent to strengthen healthcare systems through scientific and technical capacity building. And this is all along the patient journey, again, from disease awareness to diagnosis and to treatment. And one important part of that work has been working with partners like BVGH to provide training, not only around how to conduct clinical trials, but the big gap that we've understood is moving from training to actual application of that training, real world application. And we've been doing that through a program called AC3T, which is the African Consortium for Cancer Clinical Trials. And really the goal of this work and this program and the partnership with BVGH is to allow investigators to address issues in their countries and in their communities, but also develop the capacity and infrastructure to participate in global clinical trials as well. And so over the past several years and up to date, this program, AC3T, has supported over 17 cancer clinical trials being conducted by African investigators in African sites. So this is just, a snapshot of kind of our philosophy, our commitment in this space, and some of the partnerships and work we've done to date. So I'll turn it back over to you, Jennifer. Thanks.
Thanks very much, Chris. And just to highlight, we'll hear a little bit more about the Hypo-Africa study that is one of the studies that Takeda through the AC3T program is supporting. We'll hear more about the Hypo-Africa program that Will has been leading and is ongoing with, I think, all 3 of the PIs representing sites in Africa and playing leadership roles in that study during the Catalyst Summit this year. So thank you, Chris, and thank you to Takeda for the support of the 17 research programs that are ongoing, and many of the participants are here this week. I'd like to turn it over next. I'd like to introduce Dr. Chitkala Kalidas from Bayer. Chitkala is the Global Head of Oncology and In Vitro Diagnostics Regulatory Affairs and Oncology Sustainability at Bayer. Bayer is active in Africa and also planning to do quite a bit more. She's going to talk about some of those activities and plans. And again, just to highlight that very much in alignment with the goals of the Cancer Moonshot, and will be major contributors to the goals of the Cancer Moonshot through those programs. Did you want to come up here and maybe speak?
Good morning, everyone. Thank you, Jennifer, for the kind introduction, and Catherine for this opportunity to discuss what we are doing at Bayer as part of our oncology sustainability initiative. I think there's tremendous synergy here in terms of what we are all trying to do as part of the pharmaceutical industry, along with our partners in the public institutions, as well as patient advocates. And all of this being part of the platform that the Biden Moonshot offers is a wonderful opportunity. I'd like to specifically mention 3 projects that Bayer currently has ongoing in Africa. And I very much appreciate that 2 of these have already been mentioned as part of the Biden Moonshot communications that came out in association with the Africa Summit in December 2022. The first one is our liver cancer program that's ongoing in Egypt. We picked liver cancer in Egypt because there's very high burden of liver cancer in Egypt, that it's one of the leading leading countries in terms of number of cases of liver cancer due to a variety of reasons. And we have been in Egypt in terms of having a commercial presence for a long time. But still, what we noticed was that the outcomes that we saw in terms of patient outcomes when it comes to liver cancer was not what we would observe in the developed countries. And so it was not a question of whether our drugs are available in Egypt or not. It wasn't just the drugs were not reaching people when they need them. So what we decided to do was to embark on a healthcare system strengthening initiative where we worked with the primary health centers as well as the secondary centers that were serving the rural as well as the inner city communities where a lot of people did not have access to equitable cancer care. And we linked these centers to the tertiary centers, which were the real liver cancer expert centers. And this was through a process of capacity building at the different centers and linking them to the tertiary centers where we're working on creating centers of excellence that can serve the citizens of Egypt, so local capacity building. And beyond Egypt, the centers of excellence are also interested in serving the broader African community. So that is one example, and it is also, this was possible through a collaboration with the Ministry of Health and Population in Egypt, and was part of President Sisi's 100 Million Healthy Lives initiative. So it's wonderful to see that that is also that has been brought under the fold of the Biden Moonshot initiative as well. So to just give you some numbers, we have trained over 100 centers all across Egypt. And then we have also trained hundreds of healthcare professionals with respect to liver cancer diagnosis and treatment. And we've also run patient awareness camps where patients first are now they're aware of what those early signs are and what they need to do, where they need to go to get care. And so overall, this is, I would say it's about healthcare system strengthening and creating equitable ecosystems for cancer care in general. And we feel that we can build on this and serve other patients as well, that is patients with other cancers as well. So this was the first example, and quickly moving on to our initiative in Ghana. Bayer has also had a long-standing presence in Ghana and sub-Saharan Africa. We had the Ghana Heart Initiative, where we built capacity for cardiovascular care. And this seemed like a wonderful opportunity to really leverage the infrastructure that we have in Ghana to really serve the needs of patients with prostate cancer. Why prostate cancer? And we all know that patients with Western African ancestry have higher risk factors or a heightened risk of prostate cancer. And it was also recognized by the government of Ghana as part of their national cancer plan that prostate cancer is a serious burden to the country. So what we are doing right now is partnering with the Korlebu Hospital, which is a leading hospital in the capital city, Accra, as well as with the National Health Insurance Authority of Ghana and the government of Ghana. And importantly, we're also partnering with the German government to build capacity for prostate cancer care. And we're also advocating for prostate cancer coverage by the National Health Insurance Authority in Ghana. So we are very pleased with the progress that has been made and look forward to continuing the collaboration both with the Ghana government as well as with the government of Germany. And the third project, and I'll finish with this, is actually a multi-stakeholder collaboration with Duke University, NCI, NIH, Arizona University, as well as the National Brain Tumor Society. And this is about creating capacity locally in Africa and also in India in collaboration with centers in the US. And we call this the Global Pediatric Brain Tumor Network. And the idea is to really build capacity for caring for pediatric patients with these very rare tumors and understanding how centers with low resources are able to manage their caseload and exchange lessons learned with centers in high resource settings. So we have had a kickoff meeting for this, and Duke is playing the central coordination role. And we hope to have results fairly soon and read out results from this project. What I'd like to mention is that Duke is already very active in Tanzania, and we're starting with a pilot in Tanzania and also including centers in India that we already work with that have a strong interest in glioblastoma and pediatric brain tumors in general, and trying to link all of these centers through a common digital tool so that there can be opportunities for virtual tumor boards and also sharing lessons learned in a manner that would be in line with privacy requirements in the US or EU. So higher standards in terms of privacy, patient privacy and confidentiality, but being able to share best practices across regions using a common digital tool and by connecting experts across different centers. So look forward to continuing the collaboration, and also thank you, Will, as well, for the opportunity to discuss these, the progress that's being made in collaboration with so many stakeholders, both internal to a company and also external to the company. Thank you very much.
Thank you, Chitkala, for sharing that variety of programs. And just everyone to know that the speakers will be here for the day today, so you'll be able to find them to discuss, ask questions and explore additional collaboration opportunities. Next, I'd like to introduce Natanya Jennings. Natanya is the Director of Global Health Equity Platforms at Bristol-Myers Squibb, and she is going to speak to a couple of examples of BMS programs and partnerships with Africa. Natanya.
All right, so thank you, Jennifer, and thank you, Catherine, for this opportunity to share a bit about what Bristol-Myers Squibb Company is doing on the continent of Africa. I do lead the Global Health Equity Platform, which sits within Global Policy Advocacy and Government Affairs, and it's a pleasure to see you all. In reference to ongoing activities at Bristol-Myers Squibb, I'll mention three. In particular, one that I will start with is one that is sponsored by BMS for BVGH and focuses on pharmacist education. As a pharmacist myself, I recognize this as a need in sub-Saharan Africa, having visited multiple times and also served as a trainer myself. Through this program that is innovative and offering this form of training, it's not just training, but it's also offering a form of mentorship. And this is also unique in that Bristol-Myers Squibb for the first time is able to participate in this mentorship as well. In addition to this, we are also supporting the Innovative Cancer Medicine Program, which is a partnership between Bristol-Myers Squibb, two nonprofit organizations, and another pharmaceutical company. And why is this important? It's been mentioned multiple times this morning about the need for innovation in cancer care in sub-Saharan Africa. And recognizing this as a manufacturer of such medicines, it's important that we be part of the solution rather than the problem. And in doing so, Bristol Myers Squibb is providing product as well as some clinical expertise and funding to support in a project focused on operational excellence in 2 sub-Saharan African countries. And through these programs, we're hoping to learn more about the cancer excellence centers within sub-Saharan Africa. And this was also included actually within the fact sheet for the Cancer Moonshot program in December of 2022. And last but not least, I want to say that the educational component of cancer care is also something that I have been hyper-focused on as a clinical pharmacist myself, but also having had multiple visits to the continent. And one of the areas across the board that I've supported since starting this position in 2020 has been focused on education. And how is it that we are upskilling or providing this in a way that's sustainable? And one such way that we have found is partnering with major nonprofit organizations that do this on the daily. So ecancer.org comes to mind, Tech Care for All, and a few others that offer innovative ways to offer education to clinicians where they are at a time in which it's most convenient to them. We have to date trained around 20,000 healthcare providers on the continent of Africa, and there's certainly more to come in the near future. Working both in oncology and hematology, as well as beta thalassemia, it is a challenge, but in fact, we're here to meet it, and looking forward to partnering with more of you in the future. Thank you.
Thank you, Natanya. And I think particularly Dr. Biden, being an educator herself, would really appreciate the training and the many education programs that you are leading, I know, at BMS. I'd like to ask Josette Gamudu, who's the Executive Director of Health Equity at Merck, to come up and share some examples of the work that Merck is doing as well in building public-private partnerships and executing programs to improve cancer care in Africa.
Great. So good morning, everyone. It's certainly a pleasure to be here. Thank you, Catherine. Thank you, Jennifer, for the invitation. So I'll just start off by saying that Merck has really elevated access to health and access to healthcare as a pivotal part of what we do. And so within that broader rubric and umbrella of access to health, the company has put forward 3 big, bold commitments. One is we will advance health equity for 30 million people within lower to middle income countries and also within the US underserved populations. Second, we will enable 100 million more people to access our innovative portfolio globally. And that certainly is inclusive of the continent and sub-Saharan Africa. And thirdly, we will make sure that our portfolio reaches at least 75% of the globe. And so we've put forward these bold commitments, and as an organization, I assure you that all parts are working towards really thinking strategically about how we reach and exceed these goals. And certainly the way and manner through which we do that has to anchor on public-private partnerships. So that's been a very, very pivotal beacon and part of just how we go about really ultimately extending access globally. And so when you think about these commitments, we've sort of thought through the approach from a 2-pronged strategy. The first is really about equitable access and thinking about what we can do from an affordability standpoint. So specifically, as it relates to cancer and expanding access to cancer care within the continent, we've been very thoughtful around how we work with government agencies to really accelerate registration, how we think about new financing schemes and reimbursement models, and then also how we think about working with African-led distributors and suppliers to build their capacity to be able to deliver these innovative treatments. On the second front, and I think a lot of us have really talked about the importance of health system strengthening. And so we've certainly equally leaned into that as well. And so from a health system strengthening standpoint, we've really focused, at least within the continent, on thinking about the end-to-end cancer continuum. And we're doing this across breast cancer. We're looking at this very closely at how we partner with organizations to support that end-to-end continuum along cervical cancer. And we're excited to think about how we can expand our reach and our focus beyond breast and cervical cancer. So doing a lot of work around awareness, around education, but then thinking about access to preventative services, thinking about really early detection and the linkage to care. We have a few patient navigation programs ongoing really on the continent that is so focused on speeding up that linkage to care and cutting down the time to treatment. And then of course, thinking about workforce capacity building that undergirds, quite frankly, all of these efforts. And so I'll give you one example of work that is underway, and certainly this is just one example of many examples that we have. So we were excited to collaborate with PEPFAR, the United Nations Program on HIV and AIDS, Roche, and who am I missing? A lot of different partners coming together to really think about how we cut down cervical cancer among women who are HIV positive and who have AIDS. As you know, there are about 11 million women within the continent right now that have HIV and AIDS, and they're 6 times more likely to develop invasive cervical cancer. And so through this effort, we've thought about how you build and link into the current HIV treatment pathways, but in doing so in a way that really elevates the focus on cervical cancer prevention and really enabling access to cervical cancer screenings. So through this effort, there are about 12 countries within the continent that are part of this. We've been able to deliver close to 6 million cervical cancer screenings. About 300,000 women have received treatment for precancerous lesions, and certainly there's a lot of really great progress that we've seen across the board. So we're excited about this initiative. We're excited about expanding this initiative across the continent. And then I'll just end with saying that patient navigation is so critical. It's so important. And then certainly working with different organizations to think about how you build the internal digital capacity within leading cancer institutions on the continent. And so we've been partnering with a number of organizations ultimately focused on that. So thank you for your time, and certainly looking forward to engaging with you all, and happy to take any questions.
Thank you, Josette. And we will have time for questions once the speakers have all had a chance to share some of their initiatives. Josette, you touched on a couple of, I think, of really important points that were brought up today. The affordability that you're focused on for access to care, which is so important. But also, I think it's really important to look at integrating and strengthening supply chain systems and access systems within the continent and not creating additional layers, but strengthening those systems that work now and working with those systems. And then excited to hear as well about the impact that you're making on cervical cancer treatment and screening. Next, I'd like to ask Therese Lind, Vice President of Public Affairs at Electa. Therese obviously comes with a really critical area of cancer care in radiotherapy, very complementary and required to work with the pharmaceutical and other companies that bring important technologies. So, Therese, please.
So, hi everyone. Thank you for having us here today, and thanks specifically to Will and Stephen and all of you behind this wonderful summit. I just wanted to start out to say we are such impressive work to bring us all together. I think collaboration is key, and for us, Electa radiotherapy provider, we also see the importance of this, and we are spending more and more time building these kind of coalitions, being part of them, driving the agenda, thinking about, like previous speakers said, also how can we get political will, how can we make them affordable, So we're trying to explore all different kinds of collaborations to see how can we make it easier for countries, for customers, whether public or private, to actually invest into radiation therapy. So thanks so much, and we are doing our part, trying to be part of what you're doing, but also on our own organize these kind of summits, and we're actually having one in Vienna next week together with the IAEA and the Swedish Embassy and many others to continue to talk about the European grand shot. So applaud also to the US administration for launching the moonshot and also extending it globally, because it's a global world we're living in. But for us as Elekta, as previous speaker said also, for us, access to care is actually our core mission. It's in our strategy. Our mission, our strategy is called Access 2025. So based on that, you can imagine a bit what we are working on. So we have 3 pillars on that. It's access to care, it's elevation of care, and it's patient-centric care. And we have really strong KPIs that we are followed up upon to deliver on these 3 pillars. So that's very much a focus on our daily work across the business. Of course, the foundation for us is technology. So we are delivering on innovating cutting-edge solutions, trying to make the equipment smarter and easier to use, because we know workforce is a big problem, not only in Africa, but actually across the world. So that's a very common problem. And in radiation therapy, it's also critical to decrease the number of treatment sessions that you get. It's called hyperfractionation. It's well stated out in the Lancet Oncology Commission for Sub-Saharan Africa that Will and others here were part of making, where it stated that hyperfractionation is key for access. And we have the solutions for that already today, but we're also constantly driving innovation forward. So now, for example, we're working in a global consortia, talk about collaboration, with 120 hospitals, trying to push towards treating prostate cancer, for example, with only 2 hospital visits. And that's quite a big deal would we make that happen, because today that might take 28 visits to the hospital. So that will be beneficial for both patients, for providers, but also healthcare system in large. The patient part, there we have developed an patient engagement solution app, you can say, that patient can self-report daily outcomes during their treatment journey, and by thus, that data being shared, that can be used for improved and predicted care for that individual patient, but also for the big data sets. You can learn a lot about treatment effectiveness and new treatment protocols. So that's also very exciting. Well, so technology is a key, but without sufficient human resources in place, fewer treatments will be done. We were just summarizing our fiscal year, which ended a couple of days ago, and are very proud to see that we have been trained more than 34,000 healthcare professionals this past 12 months. And we are certainly wanting to increase that number even more for next year. And that's being done on our own, or most often together with partners. And we are working with many fine US hospitals here, and many of them share our interest in global health. So we are exploring that area more and more together to find partnership from US to other parts in the world using their expertise. And something we're also very proud of is the Elekta Foundation, which we launched about a year ago. And Lacey is here in the audience today and will speak a bit tomorrow at the awards dinner about the impact she and her team has been able to do the last year. But that has been, so the foundation is an extension and complementation, you can say, of Elekta sustainability agenda. Work with prevention and screening, something we are not doing as a daily business. But so important to, diagnose early. And during the first and only year so far, 2022, they started a cancer screening, cervical cancer prevention screening project in Rwanda, and screened actually 20,000 women in a rural district. That went really well, and they are now extending it to the rest of the women in that district, which is 35,000 additional women being screened starting this summer. In the fall, they're also starting a similar project in Uganda. So we're very happy to see this kind of test pilots we're trying and then trying to scale them together with partners moving forward. But you will learn more from Lacey speaking with her today or listen to her tomorrow night. So I hope we have brought forward the message that this is super important for us, and we are focusing everything we can do here to work for equitable access to quality radiation therapy in underserved regions, and they can be wherever. They can certainly be in Africa, but they can also be here or in Europe. So we are not excluding anyone. And just to finish with a recent example of how we do work is with the Aga Khan Hospital in Dar es Salaam in Tanzania, where we are partners in just one of those PPPs, where Aga Khan will treat patients under the public insurance, under the Ministry of Health, and we are providing our solution, but also comprehensive training packages where the hospital staff will receive training in Turkey, but also in site in Tanzania. So always a big piece of education coming with it as a practical example, and very recent. So thanks so much for listening, and please reach out and talk with me, Lacey, or John here, our medical affairs. Thank you so much.
Thank you, Therese, and thanks for sharing some of those great examples of the important work that Electa is doing even beyond your core technology. And I have a feeling you and Lacey will be hearing from maybe Ghana, Ethiopia, and Kenya during this week to encourage you to take some of the great programs to those countries as well. So I actually recognize that we've actually kind of nicely skewed our gender of our panel in a very positive direction without even trying, but I do, as I'm looking at this panel, I'm very impressed with the gender balance. But we did balance a little bit, so we have Eric as our kind of anchor male on the panel. Eric Broyles is the president and CEO of NanoCan Therapeutics, a company that Will is also very involved in and supportive of. And Eric is doing some great work, and he's deeply committed to partnerships on the African continent and bringing technology to the African continent. So I want to turn it over to Eric now to share some of the work that he's doing. Thank you, Eric, for being our gender balance.
Yeah, good morning. Thank you, Jennifer. As somebody with a mom and 3 sisters, I'm totally comfortable with the crowd, so and very happy to see it that way. Very excited to tell you about some of the work I'm doing with Professor Inwa, who, in addition to being the brains and the passion behind this great movement, was also a very astute inventor. And during his time as a professor at Harvard Medical School, Professor Inwa really created what we believe and what we hope, and what I've certainly made a big bet on, is a potentially disruptive technology in the cancer space. Our company, NanoCan, we are preparing to go into phase 1 clinical trials in castrate-resistant prostate cancer, doing the trial at Johns Hopkins, Dana-Farber, and Northwell Hospital. We hope to open the trial early next year. I'm praying that the technology works, because if it does, our commitment as a company and my personal commitment to the continent is that we will quickly move to open trials in Africa as well with this technology. And part of the promise of the technology is Professor Inwa figured out a way to deliver immunotherapy in microdoses in the microtumor environment, and a slow release of immunotherapy, but using about 1/600th to 1/1000 of the amount that you would get systemically through an IV. And so with those dynamics, we believe we can actually make immunotherapy affordable in Africa. And so we'll see and so my commitment, both to Professor Inwa and starting this company 3 years ago, and is that we're committed to make sure this technology gets to the continent of Africa. I've been to the continent many times before this endeavor, and certainly with NanoCan to speak with potential collaborators in Kenya and Ghana, and then throughout the continent. And so that's our hope, is that once we open the trial in the US, hopefully we'll get some good data, good safety data first. We'll move quickly to extend the trial into Africa. The second thing that we're working on, and this is more, again, my personal commitment as an entrepreneur, as somebody of African descent, is we're really committed to helping Dr. Beatrice Wiafe to build her oncology center of excellence in Ghana. And so that's a very important project, and I hope, yes. So we are committed to helping that. I'm personally committed to continuing to provide personal financial support, not through my company, but my company will, we want to make her center one of the key partners of extending our trial in West Africa. And so that's sort of the second project we're working on and committed to. And then finally, as a healthcare investor, I do have another company. I won't get into that. I'm here because of NanoCan, where I spend all my time and passion. But I have another company that has a breakthrough, and I'm committed to getting that product over to Africa. So I have a company. We're in clinical trials in England right now, and we have proven for the first time that we can deliver iron through the skin, through a transdermal patch, and also vitamin D and zinc. And so we've opened a trial in England. It's going well. That technology, again, I'm committed to getting it into Africa because there's obviously a big iron deficiency issue particularly with women. And this is an easy solution. You put on our patch, leave it on for 8 hours, and you get a very high dose of iron without the side effects that you would take from oral supplementation. And so again, that's a little bit of a sidebar, but it is a part of my personal commitment to bringing innovation to Africa and to the continent. And so thank you, Will, for putting this on. Thank you for all the other contributors for the work you're doing in the continent, and for all of you for participating. Thank you.
Thank you very much, Eric, for sharing some of those exciting developments you have ongoing. Does anyone in the audience have questions or comments? I think there must be a question out there somewhere. There's one.
Hi, I'm Emily Kobayashi from the Clinton Health Access Initiative, and appreciate the partners spotlighting the work they're doing. And it stuck out to me that there's ground shot, there's moonshot. It's all part of the strategy. The question I had wanted to pick up a point that Dr. Josette made about the Go Further initiative, which was the partnership between Merck and the US government and others. And I wanted to know, as we talk about Cancer Moonshot 2.0, what are the prospects for other public-private partnerships like that, where we have companies coming to the US government, the government putting in money as well, to be really ambitious and to think about cancer treatment in this 2.0 phase? Thank you.
Thank you, Emily. Is that question directed towards Josette or Catherine or the whole panel? Does anyone want to take that?
Hi, Emily. Good to see you. Yes, of course. I think as we think through the strategy for the Cancer Moonshot and how we engage globally, we are absolutely open to ideas and partnerships of this kind. I think public-private partnerships are really at the bedrock of what we do, particularly as we fill in gaps that the government may not be able to do by itself, but can amplify and support, especially the good work that's already being done and executed in countries in Africa. So would love to talk further if you have ideas. And I think also for us to think through how we can work with different agencies, particularly as we were talking internally earlier, with like PEPFAR, for example. How do we make sure that there is a focus on closing that loop with cancer at the back end of some of those programs as well. So there's a lot of opportunity, and I think the time is now for us to start thinking through very strategically and intentionally about how we capitalize it on those opportunities in the best way possible. But would love to maybe talk further with you as well after this. Anybody else on the panel?
I mean, yeah, I think we are incredibly excited about prospects, right, of replicating, I think, what we saw with Go Further. I think truly a lot of sustainable proven models that yield a level of impact and outcomes have been models where you are bringing so many stakeholders together, right? And I think one of the things that has been so clear to us is we were initially focused on a lot of implementation-oriented activities, but you need government there because now you're thinking about the translation to policy. And through policy, right, hopefully you can have even broader impact at a national level. So certainly I think we're very excited about what else we can, really explore with the administration and with other government officials and in a lot of the countries that we are certainly engaged and working in.
Other questions?
Thank you so much for all the speakers, and thank you for Dr. Will for including me. I am a physician from Colombia, Panama, and I have seen in Latin America how the percentage of cancer is increasing and how many families are devastated by this. So by me seeing all these initiatives, and I thank the White House for taking this initiative and spreading education, helping countries, and the goal of this Global Health Catalyst Summit is eliminating disparities and granting access to communities that they don't have the resources to educate physicians, doctors, and they don't have access to research. So I really appreciate this initiative because I know that for the countries and all the professionals, they have the resources and the knowledge. All these knowledge and resources will reach out to us to help our populations. So more than a question is I want to show appreciation to the White House and to Dr. Will and the organizers of this amazing summit. Thank you.
Thank you.
At the back.
Yep.
Good morning. I'm Paul Mobit from Cameroon. I'm here. I'll be speaking tomorrow. My question to the panel is, especially the companies, that when you develop, I just need to understand how your policy for the different Africa. Africa is a big continent with 53, 54 countries. And for me, having been on the ground in Cameroon, it feels to me like you have a single policy for the entire continent, which means you're not customizing your policy, for instance, in Central Africa, like in Cameroon, where what you do in Cameroon is going to be different from what you do in Ghana. You do a policy that works in Ghana, absolutely not work in Cameroon. So you need to customize it. And what I see working on the ground in Cameroon is that you have probably the same policy for every African country, which doesn't work. I know Russia has been in Cameroon, they've not been successful. I mean, the other one in actually driving the pharmaceutical needs of the patient. So the patients end up not getting anything at the end. For instance, in Cameroon, I believe in Chad and the other countries. So my recommendation is that you guys will need to customize your policy for the different African countries in which you work, because the general policy will absolutely not work. I can tell you about Cameroon, and I'm sure the other countries have their different issues that you have to deal with. Thank you.
Prof. Mobit, maybe I can just respond for the panel. I think that with your leadership at the Cameroon Oncology Center, and I know from speaking really with all of our panelists here that they are committed to working with leaders like you who are championing and delivering excellent care to patients in the communities in Cameroon or other African countries. So I would encourage you to speak to some of the panelists at the break, but I think everyone will agree with me that it's absolutely critical to customize your approach and your model and the partnerships that you establish in every country, including countries as, like Cameroon. So any other comments?
Thank you for that comment, and I fully agree with Jennifer. In fact, this is one of the things that I actually appreciate Jennifer's feedback very much on this, because we've spoken about this. When I mentioned the examples, I did mention Africa, but if you see the examples, they're customized to each of the countries. We look at the disease burden. In Egypt, it's liver cancer. In Ghana, we're looking at prostate cancer. While we are very much focused on Sub-Saharan Africa as a region, we are taking a customized approach, looking at the disease first, what is in the National Cancer Plan for the country, and definitely working with local experts, as Jennifer mentioned, is a priority, because we want it to be translatable locally, and we don't want to go in with solutions that are, you could consider them as canned solutions. No, we don't want to do that. And that's why feedback and guidance from experts who are already in the region is extremely valuable to us. And we seek that as part of the collaborations we have as well.
Thank you. I also appreciate that question very much. At BMS, we also don't recognize it as solely a continent, but looking specifically at countries, and certainly partnerships is essentially the way that we've been working, not just on the side of education, but also on the side of understanding the patient population and who knows them best. And as other panelists have said, working directly with clinicians in the community, as well as other respected personnel, ministries of health, et cetera, has been the way in which we have worked directly with countries and not approaching Africa solely as a continent.
So I think on that, I think that was a great question actually to wrap up this panel. We are at time. Again, I'd encourage everyone to reach out to meet with the panelists during the day and the afternoon. I know it's lunchtime now. I think everyone was encouraged this morning to visit the beautiful Penn campus that's just around the corner. I'd like to thank all of our panelists for sharing some of the partnerships and initiatives that they have ongoing in really achieving President Biden's cancer moonshot, making important contributions, not just talking about what they're going to do to partner with oncology leaders in Africa, but actually, I think we heard some great examples of all of these companies actually taking action, delivering impact, and building true partnerships to understand the needs, the priorities, and then executing on those partnerships. So I'm very excited. I know, Catherine, I don't know if you have any final words, but I know that we're excited about just the impacts and being able to point back to some of these impacts that companies are making and working with both nonprofit, academic leaders. And I want to thank Will for the opportunity to host this panel today, and look forward to meeting all of you and having discussions over the next few days here in beautiful Philadelphia. Thank you. Thank you, everyone.
Thanks a lot, Jennifer. We actually have one more session before lunch. Yeah. So, and I also want to mention something that we actually, so Catherine has been very great at this engagement. So one of the things that we're going to be seeing today is also the engagement to the diaspora and also, including here in minority communities in the United States. And one of the key people that we've discussed to engage is really the athletes. And we have today with us, I want to acknowledge, NFL stars, former players, Calvin Johnson, who is a Hall of Famer, sitting right behind there, together with Rob Sims, who is also another star, NFL star, former quarterback of the Detroit Lions. So we're going to have a chance in the afternoon, I think, since we're running out of time, to have an engagement, because Katarina is also going to be here, about how the White House is engaging diaspora and athletes like you. So with that note, I want to thank again the panel. And we'll welcome David to the front, Akila to the front, to introduce the next panel. Is Akila here? Oh, great. So we're going to welcome Professor Akila Viswanathan, who has been, we heard from earlier on in the morning, and she's going to chair the next panel. Thank you, Akila.
Well, now we can switch and say good afternoon after a very exciting morning. So we're right on time, actually, and very, very honored to continue this session from today. We're going to be discussing the Lancet Commission's Global Health Impact and doing the Meet the Press session. As Dr. Ngwa just mentioned, we have David Coleridge, who's been speaking with us before. He will be the first speaker in the panel. I'd also like to invite up to the table here all of our other speakers who will be commenting. So we have Dr. Ophira Ginsberg, who's our Senior Scientific Officer from the National Cancer Institute Center for Global Health. We have Professor Hedy Hrysak, who's a professor from Memorial Sloan Kettering's Department of Radiology and leading the Lancet Oncology Commission's medical imaging and nuclear medicine area. And then we have Dr. Raffaella Casolino, who's at the World Health Organization in Geneva, Switzerland, and also serving on the Lancet Oncology Commission. So I welcome our speakers up to the table, and then we'll begin our session with their talks.
Well, hello again, afternoon. So I'd like to thank Will again for giving us the opportunity to host this session, looking at a broader session looking at the Lancet's Commission's programme and our role in global health and health activism. And it's very apt that we hold this session today. This year is the 200th anniversary of the Lancet. And the Lancet was founded in October the 5th, 1823, by a man called Thomas Wackley. And Dr. Wackley, he was a 27-year-old pharmacist, surgeon, sometimes boxer, back in the 1800s, who founded the Lancet Journal. And throughout the course of his life, he also went on to become a member of Parliament in the UK government and a coroner. So he was a very busy man, a polymath of the era, but also a great Victorian reformer. Now, his original intention when launching the Lancet was to publish reports of the Metropolitan Hospital in London, which at the time were hugely profitable endeavours and really only published by a small clique of doctors. He wanted to dismantle this private monopoly over information and knowledge. He wanted to root out corruption and quackery, and he wanted to challenge the medical establishment. He fiercely campaigned against incompetence, privilege, and nepotism. Now, superficially, medicine may seem like it's very different today, but if you scratch the surface, I think regrettably many of these traits still remain. The huge inequalities in the 19th century are just as profound today. Imbalances in power, inequalities in resource, disparities in access to high-quality healthcare, they remain across all societies and countries worldwide. So to Wackley's idea that the Lancet should be more than just a scientific journal of record remains a strong guiding force for the editors across the 24 journals we now publish. We believe that the academic medical community is a vastly neglected contributor to social progress. We believe that through extraordinary partnerships, the science we publish can be an instrument for change, and it can accelerate action to advance health and health equity. We believe that medicine and medical research are political as well as scientific endeavours, and through our commissions programme, which started with the first report in 1866, so we've been doing these a while, is now a vibrant editorial undertaking across all of the journal portfolio. And we believe that these commissions can play a vital part in health activism and are instruments for change. So in this session, it's a great privilege that we have 3 leads on 3 ongoing commissions, or 3 commissions, I should say. The first commission we're going to hear about is one that will be published later this year. The second commission is one we published in 2021. And the third commission is one that's at its very earliest stages. So you'll see a little bit across the whole gestation of 3 different commissions. So I think I'll hand back to our chair to introduce the speakers.
Thanks so much for the overview of Lancet commissions, and I think that many of you are aware of how they come out. We heard this morning from Dr. Noir and other colleagues who have been involved in the Sub-Saharan African Cancer Commission and the Lancet Oncology, but what we often don't hear about is how they come together, and how they're really labors of love by so many volunteering their time. So without further ado, I'm just going to say a few words about the data that really drove us to consider doing a commission in the first place. I mean, it seems like a monumental task sometimes, as I'm sure many people here know, but I hope, like with other commissions, including the opportunities to collaborate with each other, we can actually take the actionable recommendations forward into the hands of people who need it, to policymakers, ultimately to patients, and to those at risk of cancer. Otherwise, they're really just reports that are published. So I'm going to skip through some of this, I think, because in the interest of time, and because you already know that some of the global cancer statistics were covered this morning. But just quickly, in 2020, 9.2 million women were diagnosed with cancer. And incredibly, almost half that many died of cancer, right? What you might not know is that most of these deaths were premature, meaning under the age of 70, and most were actually preventable deaths. And where are these occurring? Well, everywhere, as you know, not only in the African continent, but in every country. And in fact, some of what our purpose is in the commission is to draw attention to data that's been hiding in plain sight. What many people don't know, right? We talk about women's health in terms of maternal mortality, sexual and reproductive health, and rights, critical to women's health and to development. But what many people don't seem to appreciate quite yet, despite some efforts to change this situation, is that cancer is one of the top causes of mortality in all countries among women, and premature, top 3 causes of premature mortality. Cancer is the top in all but 2 countries. So cardiovascular disease and cancer together are generally the top 2 in the top 3, okay? We're talking about a huge amount of care that's needed, a prevention that's needed, and an understanding also of cancer risks that haven't really been explored. The slide I had before showed a map where the only reason I mention it is just to show the blue, where you see that lung cancer in the blue countries, that is where lung cancer is the top killer of women due to cancer. That's 28 countries. So it's not just breast and cervical cancer, although that is incredibly important. And we spent a lot of time talking this morning, and I hope we address the preventable burden of these cancers during this few days. We did this as well in a series published in The Lancet. I had the pleasure to help put together with about 40 people in 18 countries. That's now 7 years ago. And we had a series called Health, Equity, and Women's Cancers. And just for those of you who are wondering, a series in The Lancet or The Lancet Oncology are also very important tools to bring attention to a major public health issue. But these are mostly reviews, synthesis of existing information and review, whereas a commission is actually mostly original research that informs a set of recommendations. In this case, you can't see it here, but the second commentary was called Women, Power, and the Cancer Divide. And we were so excited to have Dr. Michelle Bachelet write this commentary back in 2016 when she was still the president of Chile. She went on after that to become the UN Commissioner for Human Rights. And so the concept of the interaction of women, power, and cancer is what got us thinking about what we need to do to move past just incremental changes, which we're still sadly seeing, despite having these two important global programs that you've heard a bit about cervical cancer elimination. You'll hear also, I hope, about the Global Breast Cancer Initiative that the WHO has been leading and launched a new report, the first ever implementation framework, kind of jargon for a technical document to help countries address the growing burden of breast cancer, which is still the #1 cause of cancer-related death among women in 108 countries. The map showed you that. This was just launched a few months ago on International Women's Day. So we're making progress, but it's still incremental. And what our commission is calling for is gender transformative action, okay? So we often get asked, I get asked this a lot actually, why focus on women? Now, I think it's kind of funny to ask that here because I see there's a lot of women here and there's a lot of almost all women panels, which is really refreshing to see. There are many reasons why people ask this. Sometimes they're slightly cynical questions. Often they're good questions coming from the right place. And in fact, you know, the thing that goes along with that is, don't men have a big burden of cancer too? In fact, don't men have a higher risk of developing and dying of cancer? And the truth is, yes. There is a slightly higher risk of developing and dying of cancer if you are male. And by the way, I do recognize that there's more to gender than biological sex, and we are very clear about this in the commission. When we're talking about, broadly speaking, men and women, why should we care so much about women with regards to cancer? And the reason is multiple, but I'll start with something a bit cheeky. Women are just like men, only different. Okay, so what do I mean when I say this? First of all, women do have a high risk of cancers that men also get, like I mentioned, lung cancer, colorectal, liver cancer, and others. But there are also data hiding in plain sight, which should prompt us to think more broadly how, if we address some of the issues of power asymmetries, women's opportunities to seek care, women's access to care when they have the burden of caregiving at home, and also cancer caregiving, by the way, which is something we also talk about. But what about when we look at younger women? And so we published this, Dr. Salvatore Vaccarella, Dr. Freddie Bray from IARC, and myself when I was a visiting scientist at IARC a couple of years ago now in the Lancet Oncology. And we looked at the burden, in fact, the incidence of cancer among adults under the age of 50. And guess what we found? 2/3 of the 3 million adults diagnosed in 2020 under age 50 were women. Nobody knew that. What does that mean? What does that mean for families? What does that mean for the children and for society? So I promise you I will end on a hopeful note, but it is important to look at what's really happening. This was a seminal paper, really a landmark paper by Florence Guida and Valerie McCormack at IARC, and I'm pleased to say I was among a group of authors on this, including other commissioners. And this was the first global and regional estimates of maternally orphaned children due to cancer. And I'll just give you the quick one-liner. Just in 2020 alone, globally, there were more than 1 million children who were rendered maternally orphaned because of a cancer diagnosis, because of the death of the mother. Again, that's not to say the death of the father doesn't matter. Of course it does. But in many places, women are having children on their own. And in many situations, of course, when a male member, when the father dies, frankly, it doesn't make as much of an impact. And there's data to support that. In many places of the world, when a child loses their mother, they're relegated to second-class citizen in their own household. And this contributes to the cycle of poverty. Another question I get asked a lot is, okay, so we're talking about women dying of cancer. Oftentimes it's preventable, right? It's premature death. So why didn't this woman come sooner? This is a clinic photo that I took a number of years ago where I used to work in rural Bangladesh. And we see here a very advanced breast cancer. And unfortunately, this woman's quite young. She was 42. The tumor took up most of her breast. She came in with a friend, not a family member, because her family had abandoned her. And when we asked her, did you know you had a problem? I mean, of course she did, right? Most of the women we asked, and we've published on this, know they have a problem, but they don't feel they can. They don't have the agency. They don't have the opportunity necessarily to come for care. And that question even is, for those of you clinicians in the audience, is a loaded question. It implies a bit of blame, doesn't it? Why didn't you come sooner, right? So the truth is, she might have come sooner. In fact, there's a lot of research to show that in many situations, these women who've come with these very advanced breast cancers have already been to 3 or 4 clinics. They've already been to several healthcare providers or perhaps traditional healers. And sometimes they're told to go home because they're too young and it can't be breast cancer. And sometimes they're treated wrongly or they're actually discriminated against because they are poor or perhaps a person of color. And I'm not just talking about low and middle income countries. So in this commission, which is a sneak preview really, we can't show you the findings yet, we address these challenging questions and we provide a lot of new data, including a synthesis of the literature that looks at asymmetries of power and agency, access, and rights to seek care and to obtain care and to be able to stay throughout the continuum of care, regardless of what kind of cancer we're talking about. It's not just breast and cervical cancer, and it's not only in the African continent, it's also in Canada, it's in the US. And so is cancer awareness the answer? Again, this is part of the solution. Just like funding. Somebody asked earlier, what if there was a global fund for cancer? Well, I don't think anybody here in this room would say, we don't need more funding to help solve the problem of global cancer, right? But that's not quite enough. Just like technology alone is not a solution. This is Dr. Verna van der Pooij, who I'm very honored to say is one of our 3 co-chairs for the commission. The other is Dr. Isabel Sorio-Mataram, who's at IARC. And Dr. van der Pooij has frequently said this to us. She is a very active and busy clinician at Korle-Bu Teaching Hospital in Ghana that we've heard a lot about today. When she says this to her patients, and she still sometimes does, because she's frustrated like any other busy clinician, why did you miss your last appointment? Why didn't you come sooner? And her patients keep reminding her, and I say this to remind myself and all of us, right? You have to understand me to help me. So the situation, the context in which the woman whose photo I showed earlier, in which she lives, must be addressed, or else we're not really going to make impact. The other part of the women power and cancer nexus is about women as healthcare providers. We heard a lot this morning. I'm glad to say I see Dr. Miriam Mutebi, who's one of our commissioners as well, and the incoming president of Aortic. Super excited about this. We talk about caregiving and cancer and the workforce. The workforce is so critical. We need to expand. We need to make better use of the healthcare workers we have, right? But what wasn't mentioned this morning is that much like healthcare in general, the phrase delivered by women, led by men, which was a major WHO report a few years ago with women in global health and others, led by women, led by men is not necessarily the problem in and of itself, but it's the way in which we are able to make decisions that take into account these myriad factors, right, that women have as the lived experience. Yeah. So just a quick moment to circle back to the UN Women and the way in which the Sustainable Development Goals are intersecting with gender in all ways, not just for cancer, right? So we see here gender equality is a right. Fulfilling this right is important to overcome some of the world's most pressing challenges, including the pandemic, by the way, right? Women's rights were set back, as were many women leaving the paid workforce, and don't even consider how much unpaid caregiving is happening at home. And that women are not only affected by these problems, but we are part of the solution. Women have great ideas, women have ingenuity, women have leadership potential. And I'm not going to say anything about we need to empower women. Women are already empowered. We need to get out of the way and let them take their power and use it. So a lot of what you're going to hear about in our commission report is how women interact with the cancer system in these various ways, including as unpaid caregivers, and in all these domains, the overlapping types of discrimination that impact upon our opportunities to have the best possible outcomes. And I hope you'll see that by studying the social inequality, cancer risk and outcomes, and women in society, and that nexus will help inform best practices also that are applicable to people of all genders, really. In a way, we could think of this as a bit of a Trojan horse. So we are taking purposefully an intersectional feminist approach to cancer in this commission. We're investigating what you can see up there. I know I'm out of time. Those are our goals. And I'm very excited to say that we have 21 commissioners, 8 mentees. We've got a 6-person patient advocacy committee, which is so vital. Patients have to be at the center of not patients, people who've experienced cancer. Even changing our language is important. Right? Those are representing many different countries, including our advisory board membership. We've got too many partners to mention, but I just want to say I'm very excited to finally announce that our publication date and launch have been set for September 27th, which will be in Geneva, so stay tuned. And please, let's think of these commissions not as a report, as an end, but really as a beginning. So we hope everyone will join us in this activity. Thanks so much.
Thank you so much, Dr. Ginsburg. That was outstanding. And we'll save questions to the end. We'll next hear from Dr. Husek, who is speaking on the Lancet Commission on Medical Imaging and Nuclear Medicine.
Well, thank you very much. My voice is not good, and for that I apologize. Okay. Well, I'm supposed to know how to work the slides. It's not coming up.
You just have to press.
It's coming up on the screen, but not.
There it is.
Oh, perfect. So we're going to address a Lancet Oncology Commission on Medical Imaging and Nuclear Medicine. Being a physician, we always start with our disclosures, and those are my disclosures, none of which really interfered with the work that I'm going to present. When we look at the Lancet Commission on Imaging, very briefly, it's not the technology that really is the cause of inequity in healthcare. It is our will, our vision, and coming together. This commission, as all the others, it really takes a village. There are many commissioners, there were authors, and I just would like to show the authors. The reason is that we were multidisciplinary, interdisciplinary, and of course, we were international. Very happy to say that our commission, being technology-driven, was not supported by the industry. We know that there is a lack of equipment around the world, and we never wanted to be criticized of being in any So, sorry, we never wanted to really be criticized of being in jeopardy, that we were supporting GE, Siemens, and so on. The commission was supported by the societies from radiology, nuclear medicine, by medical oncology such as ASCO or ESMO, by ESTRO, and were supported by the societies around the world, including aortic. We saw this slide in different forms, and those are the data actually from a recently published paper in Lancet Oncology, still showing us that 75% of life years lost to cancer are in low middle income countries. Yet they only have 5% of resource. We also heard over and over that 80% of cancer occurs in the low middle income countries. And as published in the Commission on Sub-Sahara, which I think it's really alarming, that the burden of cancer projected to grow 1 million deaths till 2030. So there's no question that we have a problem. As we start looking at our commission, we quickly realized that there were no global benchmarks on either the equipment or human workforce. And deeply grateful to IAEA for helping us get the global data. This slide, all the others you're going to see, it is very disturbing. When you look at the number of CT scans in the world, then you see that United States, western part of Europe or Australia are very well equipped. They have more than 30 scanners per 1 million inhabitants. We are here to discuss Africa. There are parts of Africa, many parts, that have less than 5 CT scanners per 1 million inhabitants. We just heard technology is not a solution. No, it's not a solution. But without technology, you cannot provide proper cancer care. It isn't just for CTs. We can look at MRIs. The picture is even worse in Africa because there are countries and countries that actually don't have an MRI unit. PET-CT, we heard about PET-CT and importance of nuclear medicine. Well, as we look at the PET scanners, there are huge parts of Africa that, as you can see, have no PET scanners or only 1 or 2 per country, per 1 million inhabitants. As we think how to, and I'm so glad that there are policymakers in the audience, cancer care is a continuum care, and we have to look at all aspects, certainly prevention, screening, diagnosis, treatment, but diagnosis and treatment and follow-up without the equipment are always going to be limited. How about the workforce? We know that there is a shortage. There is a workforce shortage around the world. In radiology, looking at the radiologists, again, once again, the United States, it's relatively well has with the workforce. Also, we complain all the time, but as we compare the United States to Africa, there's really nothing to complain. There's only to help. In Africa, the number of radiologists, if it's in yellow, it means there are less than 5 radiologists per 1 million inhabitants. You cannot make the diagnosis. How are you going to move forward into treatment planning? And then, unfortunately, there are parts that they have only 1 or 2 radiologists per 1 million inhabitants. We always say, picture tells 1,000 words. And when you see that color of yellow and gray overwhelming the African continent, you know that we have a problem, but we also have an opportunity to solve the problem together, like Will said, in a collaboration and win-win situation. Here are a number of nuclear medicine physicians. We heard about the importance of nuclear medicine in cancer care. Africa really has its alarming shortage of nuclear medicine physicians. There are parts and parts of Africa that have less than 5 or have no nuclear medicine physician present. So education, talking about the workforce as well as the equipment, are absolutely staggering. Now, we often ask, what does make a difference in patient outcome, or can we avert the death? If we don't do anything, then by 2030, we're going to have 76 million deaths from cancer. If we only pay attention and build treatment, which means radiation oncology, surgery, and chemotherapy, there is no question we're going to improve the outcome, and we can actually save 5.4 million. But if we include imaging, imaging is simply a GPS to know where you're going, then you're going to avert 9.5 million. So by providing continuum of care, we can avert 12.5% of all cancer death. That part of averting cancer, of course, is not equal across all countries. And the impact is the greatest in the low middle income countries, where it's 10 times higher than in the high income countries. But there is another thing. In low middle income countries, by providing the infrastructure, we can actually avert 47% of cancer death. So as we look at the cancer moonshot, the greatest chance of success is actually investing in the low middle income countries. And that investment has to be stepwise. The greatest immediate benefit will come just from investing in X-rays and ultrasound, and then go to the higher end equipment. So that averting death, how is today? As a part of our commission, we also did a granular look at the world. And since breast cancer is the most common cancer in Africa, I'm showing you breast cancer. The 5-year net survival of breast cancer in the United States is now over 90%, depending who you read, between 92 and 95. 5-year cancer survival in Africa looks very different. There is some hope. Algeria, in all of our studies, really stood up as having a better cancer care than the neighbors. But look at the sub-Saharan Africa. There are countries and countries where a woman has no chance of a 5-year survival. It's actually like 5%, 10%. And when you see those colors and somebody asks for metrics, let's hope 5 years from now, as we do this granular analysis, that Africa will look differently. Let's take another cancer because we are equal opportunity here. So we look at prostate cancer. Prostate cancer survival, 5-year net survival in the United States is now 98.5%. And in Africa, it's a death sentence. In many parts of Africa, it is a death sentence. And I know you are looking again, Algeria, Libya, there's a little island that's also on the west part of the coast that looks a little different, but big parts of Africa are really in red or dark zone. And that has to change. And this is our benchmark to look for, to change together in the next 5 years. For those entrepreneurs in the audience, is there a return on the investment? For every dollar invested, there is a return. If you only provide treatment improvement, there is in turn a return of $6.15. But if you include imaging, so you provide continuum of care, then the return on the investment is $12.43. You double your investment if you understand that cancer is a continuum. So what have we done so far? Meetings, presentation. WHO is including this data in their new policy. IAEA started Rays of Hope, partially based on this data, both improvement in survival as well as return on the investment. But the one that I would really like, that I am really proud of, and I think David is, that we actually have 2 WHA resolutions. It's not only having equipment, but being able to be affordable. The resolution on diagnostics, which is mostly pathology and laboratory medicine, is going to be voted on May 26th, in a few weeks. After that, we are already starting looking at the resolution on imaging. Imaging, as you know, studies are expensive. And we're really asking, this is a wonderful opportunity with help of Will come to many of you, because we really need support from African countries that this resolution is needed. Because once it's a resolution approved, as you know, it becomes a part of the policy. And then hopefully every country that has national health care will include and will pay for imaging. So this is from our will. We say Ubuntu, and I think we can work together because we are as we are together. And with this in mind, thank you very much. Apology for my voice.
Thank you, Dr. Husek. Again, outstanding. We'll now introduce Dr. Rafaela Casolina from the World Health Organization, who is going to speak on the new Commission on Cancer Omics.
Good morning, everyone. Thank you, the organizer, and thank you, Will, for the kind invitation. It's a big honor for me to be here today and to present the formation of a new Lancet Oncology Commission on Cancer Omics and Precision Oncology. Now I am in a difficult position after the previous presentation because of course, how can we talk about access to innovation and to these novel approaches if many people in the world don't have access to the basic diagnostic tools? But during the presentation, I will discuss with you the importance of starting the discussion because we can deny the importance of this novel approach. It's not progress? Yeah, thank you. Before starting the presentation, I want to underline that I am currently working for the World Health Organization, but today I'm not speaking for WHO. The views are my own. Precision oncology is rapidly changing and improving the way we approach and treat cancer, but major challenges are currently limiting the realization of its full potential. And this is not just a missed opportunity to improve the lives of many people with cancer, but also a missed opportunity for research. Most importantly, this novel approach to the way we approach and treat cancer is preventing us to give access, equal access to cancer care to many people around the world. Now, this commission, with this fancy title, one could think that the focus of this commission is about technology and discovery science, which is not the case. This commission is about patients. It's about adults with cancer, kids with cancer. It's about equity and inclusion, and it's about human rights. Because we, as a medical community and society, have the responsibility and the moral obligation to ensure the right to the highest attainable standard of health and right to enjoy the benefit of scientific progress and its applications for every patient around the world. But let me introduce you to the concept of precision oncology and why the current approach, the current model needs to be changed. Precision oncology is based on the use of molecular profiling to select the right patient for the right drug at the right time. And this progress have determined a rapid changing of paradigm from the previous and traditional unselected approach based on one-size-fits-all chemotherapy to a more personalized approach, where we improve the efficacy of treatment on one side, and on the other, we avoid ineffective treatments and related toxicities and costs in patients that are not likely to benefit from them. But this changing of paradigm has been possible thanks to major progress in next-generation sequencing technology and large-scale cancer genomics initiatives such as the TCGA and ICGC that improved our understanding on the complex tumor biology, revealing that similar tumors from the same anatomic site can be fragmented in multiple cancer subtypes, sharing unique molecular alterations that can be therapeutically targeted. And this is the concept, the basis of the concept of the precision oncology. So using treatment that target specific alteration in the tumor. And as a result of this progress, hundreds of target therapies have received tumor-specific or tumor-agnostic approval over the past decades, and many, many others will be available in the future. And if we look at the biomarkers are the target of our treatment, we can see that the number of biomarkers will increase exponentially in the coming years. So this means that overall, the applications and indication of precision oncology will expand dramatically in the future. But what is the promise of this novel approach? So precision oncology, precision cancer care doesn't have just an impact in the short term by improving patient outcomes, allowing access to the optimal personalized treatment as a standard of care, or to the most innovative treatments in a timely manner through the enrollment in clinical trials. But also, and most importantly, the major impact is in the longer term, thanks to the generation of data from real-world experience and from research. But if this is the promise, this is the current reality. There are major barriers, both at an individual level and system level, that are currently limiting and affecting the whole system. And barriers to the access to precision oncology are at several levels, and discussion can be endless here. Also because we have different situations in different countries, and so it is impossible to generalize the barriers. So the challenges are patient level, physician level, infrastructure, policy, and last but not least, industry. That is one of the major driven of improvement in technology. So it's very important, but it's also one of the major limits to the access to precision oncology due to prohibitive costs of diagnostic and treatments. So as a result, access to testing and access to drugs is currently limited to a few lucky patients in privileged countries, while low and lower middle income countries have basically no access to this innovation. And I want to underline that the WHO list of essential medicines includes only 5 target therapies. 3 of them are approved, are included in the EML for the treatment of lung cancer as a class of drug. So this means that according to the WHO EML, target therapies are not affordable and not available for many countries. And the situation for clinical trials is even worse, because access to clinical trials is currently limited to the northern regions of the world. In general, only the 5% of patients with cancer have access to clinical trials, and of course, marginalized populations have no access to clinical trials, including ethnic minorities and other marginalized groups. So this means that basically everything we know, or almost everything we know about cancer biology and about how treatment works derives from white population. And so this is a guess, and in medicine we don't want to guess, we want data. The situation for data is even more complicated. I think that they're the wrong slides, so I'm sorry, but I had different slides uploaded, but it's not a problem. So the situation for data is even worse because there is a complete the way we collect the data, both from clinic and genomic studies, is in a complete state of disaggregations. So we need to standardize methods for data collection and to improve data sharing. And this is one of the major challenges for the next decades. So summarizing, the current system is unsustainable, inefficient, and ethically unacceptable. So we need to do something to improve the status quo. And this is our Lancet Oncology Commission. So we will try to improve the current model of access to precision oncology and to related to data. So we will proceed with the analysis of challenges, both those related to the implementation of precision oncology, data management and control, and we will provide recommendations to improve delivery of effective, equitable and sustainable precision cancer care, together with harmonized data collection and enhanced data sharing, to impact on global cancer control through better care, cancer care and research. The proposed approach, given the complexity of the issue, is global, multi- and transsectorial cooperation and collaboration centered on patient needs that takes into account the sustainability and diversity of health system and regulatory authorities. We will try to propose integrated healthcare solutions, but of course in a context-specific manner, because the one single model may not be appropriate. And as I said, we will try to harmonize health system and regulators' approach to this novel cancer care model and the harmonization of data management and control. The International Cancer Genome Consortium, Accelerating Research in Genomic Oncology, has proposed, and he's leading this Lancet Oncology Commission thanks to its 15 years experience in collecting, collating, and sharing clinical and genomic data. But we have different stakeholders, and many others will be joining us in the future. It took 1 year preparation to reach this point, to engage the stakeholders, to identify the priorities, and to identify the subsection and section leads. And the Lancet Oncology Commission was announced last February. We will have these 8 subsections, one focus on the current landscape of access to precision oncology around the world, clinical and patient-based challenges of precision oncology, policy, clinical research aspects, data process and control, ethics, governance, and legal consideration related to data process and control, education and training, and future-proofing, and we will conclude with a call for action. We will also have 2 cross-sectional working groups, the patient perspective and the new generation leads. You will see a lot of young faces in this commission. And so in conclusion, precision oncology represents a great opportunity, but there are many challenges that needs to be addressed. The status quo model is unsustainable, inefficient, and ethically unacceptable. The processes and policy landscapes need to be implemented and streamlined, as well as that related to data. We need to harmonize the methods for data collection and data sharing with a long-term vision and with novel approach based on honest and true collaboration at a global and multi-sectoral level. Because if you want to go fast, you go alone, but if you want to go far, you go together. So let's catalyze collaborations, and thank you for your attention.
Well, thank you to this amazing panel. It's really enlightening to think about everything related to women in cancer, the impacts of breast and cervical cancer, the lack of treatment options for patients around the world in so many countries, and its impact on society as a whole. So we'd like to open this up for questions from the audience. And, you know, I was intrigued by so many of the points that you all made, and the importance of thinking about, you know, where we are in terms of being able to simply just diagnose women and people with cancer before the cancer may have metastasized. You know, something we take so for granted here in the United States, but that is not to be taken for granted in most parts of the world. You know, I was curious for Dr. Ginsburg. You made some really astute points about the relationship and how women are, you know, starting to see some of the impacts that we talked about earlier, you know, some pap smear screening, some of the you know, impacts that will have in the longer term. I wondered if you can comment on how that is differing globally and what you're seeing as the most active and effective intervention that we have going on in underserved areas in the world right now. What are some of the ways that we can say, you know, these are our short-term interventions that are proving themselves to be quite good, whether it be in the HIV positive population or the HIV negative population, but in an underserved area?
Thanks so much for the question. In fact, although I didn't really touch upon the way our commission is structured, I probably should have. We don't actually do a review of interventions in the commission report, but that's absolutely fair question. We are trying to look more holistically at what is impeding our progress because we already have the tools. So cervical cancer is a great opportunity to discuss that as an exemplar for health inequalities, right? 9 in 10 women who died of cervical cancer in 2020 were living in a low-income or middle-income country. I mean, that's just appalling. We've had vaccines for, 15 years, more than that. We now know that 1 dose in most settings in women not living with HIV, for example. And in the younger age groups, 1 dose is likely to be as effective. And we're looking at very exciting developments in this domain. We now have targets. We have the 90-70 strategy of the World Health Organization's efforts to accelerate the elimination of cervical cancer. We know about cost effectiveness, my goodness. So why haven't we moved the needle further by now? And that's really at the heart of what we're trying to do with our commission's efforts, to look at those asymmetries of power in terms of decision-making, in terms of political will, who is doing the asking, right? And how are we looking at equity with respect to cancer care and control? If we can't get cervical cancer right, then what are we doing, right? Yeah, thanks.
It's an outstanding point. All right. Dr. Husek, you mentioned the lack of resources in terms of imaging technology, right? That there are very, very few centers around the world that have that, and what the incredible impact is for you to, begin having imaging technologies. It strikes me that that may be quite challenging, getting a PET scanner versus even just sometimes ultrasound or X-ray could have its own impact. Did you look at the types of modalities, the differences in those rates?
Yes, we did. And for the low middle income countries, the greatest impact, you have to go stepwise. You cannot jump to PET and not even having ultrasound. So the greatest impact would be just X-rays and ultrasound. The second one is CT. Now, it's we looked not only in Africa, we really looked globally. So in the United States, the greatest impact is actually having a PET CT scanners, because we already have everything else. But for Africa, it was no question X-rays and ultrasound will go a long way, but it's not just having a machine. If having somebody that knows how to operate and having somebody knows how to read. And so it's that's why I really believe, right, with this report, and David knows that, a number of industries were running to the political power, especially in Africa, and got great orders on CT and everything. But we know of cases, and sorry to mention Nigeria, where PET CT, Siemens PET CT, was sitting on the boat in the harbor, and they couldn't even import for 2 years. After 2 years, the technology was old. And I was rotten, basically, because it was on the boat. So as we look at the strategies, please make sure we have all lined up, not just give this and give that. And there was a great report from the IOM on the equipment in Africa, actually. Very often equipment that's given doesn't work. Equipment that's bought stays in the boxes. So it's a big problem, but I think step by step, and this conference is one of them, this catalyst, can really make a difference.
If there's one kind of consolidating concept, I think, from this meeting is that education is the very first and essential step in making everyone here feel that you can contribute in a meaningful way, so that there is a growth of knowledge, which then sows the seeds that sprout in all of our areas. And so part of the Commission's effort is to continue to sow those seeds of knowledge and understanding for global impact. So hopefully you'll all participate in more educational efforts and continue with the rest of the meeting as well. We are at time for lunch. I will say that our speakers you may want to come and ask them questions. So if they have time to be here for you afterwards, but you are, at the 1 o'clock hour. So it's been a long morning and a really wonderful morning. So thank you to all of our esteemed panel and to Dr. Will Nikwa for organizing. And we have Dr. Avery here to direct our next steps. Thank you all.
Yeah, thank you for a great session. I mean, this has been a great day, and we're not done yet. We have another session, and we have a dinner tonight. So for lunch, we have lunch in the Hall of Flags. So when you go out the door and you make a right, you walk about, I don't know, maybe 10, 15 feet, and the Hall of Flags are right there, and you can have lunch. If you don't want that lunch, there are many food trucks around. In walking distance, you can get food from any kind of flavor or part of the world that you're interested in. There's also a food court that's in the Hall of Flags. If you don't want the free lunch, you can go there also. So I think that hopefully it's still nice out. You can still walk around, but there are many options here on campus. So we will meet back here at 2 o'clock to continue for our ambassadors and diaspora session. And I hope everyone comes back and enjoy the rest of the day. Thank you, everyone.
Hall of Famer and legend, also called as Megatron, Calvin Johnson. Please come to the front. So this is the unique thing about the summit. Imagine ambassadors and players sitting together talking about cancer. It's amazing, right? And so we are going to get right into it. We are going to actually start by listening to some words of support from a number of people. So we're going to play two videos, one from the former president of Ghana, and then one from Eric Holder, who was the former Attorney General of the United States. So go ahead with and Andy Reid. Andy Reid, the coach of the Kansas Chiefs, who won the Super Bowl just recently. Okay, so let's go ahead and play the first one.
Thanks to the organizers and especially my friend George Tim for inviting me to speak at the Global Health Catalyst Summit, which is, I think, an important platform for catalyzing collaborations to advance global health equity and social justice. You know, as Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Now, as a former Attorney General of the United States, I've witnessed firsthand the impact of health disparities on individuals and communities, especially those who are marginalized and oppressed by systemic forms of racism, poverty, and violence. I've also seen the power of collective action and collaboration, which the Global Health Catalyst Summit has been championing to address disparities in the United States. Thanks to the
Yeah, having a couple of technical issues, but we'll get that fixed.
Injustice in healthcare is the most shocking and inhumane. Now, as a former Attorney General of the United States, thanks to the organizers and especially my friend George Tim for inviting me to speak at the Global Health Catalyst Summit, which is, I think, an important platform for catalyzing collaborations to advance global health equity and social justice. You know, as Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Now, as a former Attorney General of the United States, I've witnessed firsthand the impact of health disparities on individuals and communities, especially those who are marginalized and oppressed by systemic forms of racism, poverty, and violence. I've also seen the power of collective action and collaboration, which the Global Health Catalyst Summit has been championing to address disparities in the United States and globally, especially on cancer. Now, cancer is a leading cause of death in the United States.
Since we're having some issues, they're going to be fixing that, but we're going to go ahead and continue, and then we'll come back to these videos. So we're going to go ahead to the next. I'm going to invite, like we mentioned, you know, the White House has really been interested in engaging. Like Catherine said earlier on, when President Biden launched the Cancer Moonshot, he said everybody can do their own part. You know, that really means that everybody, right? So Catherine has really been at the forefront of the White House engagement efforts. So we're going to welcome her to the podium to make some remarks on engagement with the diaspora and the ambassadors. So let's welcome Catherine, please.
Well, hello again. I think one of the key things that we can take away from this morning's conversation was just how important collaboration is and how important bringing the right players to the table, my pun with the NFL players over there. No, I'm kidding. To the right players at the table, including the federal government, academia, and all of those who are so intimately involved in delivering for cancer care. But I would like to add another component to that, and this is bringing people who might not necessarily be that involved into the fold. but want to have an impact on healthcare and patients as well. The president knows this really well. In fact, when he reignited the Cancer Moonshot, he started for the first time ever what he called the Cancer Cabinet, bringing together several different federal agencies and departments across the board. So yes, of course, we have NCI and NIH and FDA, but we also brought together NASA and the Department of Commerce, Department of Labor. And why did we do this? Because it brings together ideas that may not have been thought about before. It brings together resources and tools and focus that is different so that we can deliver for cancer patients across the spectrum with innovative solutions. And today, I'm here with a special ask for the diaspora. We invite all of you here to help us build on this momentum, to expand on this foundational work that has started, to help us break down the barriers and silos that exist, to help extend our reach even further. And you are especially and uniquely positioned to be incredible change agents when it comes to delivering progress, both here in the United States and back in your own home countries. And more importantly, you have the will to do so. Being from South Africa myself, I understand the incredible desire to see the people of the country where you were born not only survive, but thrive. So let's do this together. We invite the ambassadors, we invite the NFL players, we invite everybody here today to be a part of this global movement to end cancer as we know it. Thank you so much. And Will, I will turn it back over to you.
Okay, we're going to play some other remarks. We're working on the Eric Holder video, but we're going to have some remarks from Andy Reid in support of the Cancer Moonshot. So we can load that video.
Doctors, this is Andy Reid. I'm the head football coach of the Kansas City Chiefs, and it's my privilege and honor to just be able to say a couple words to you of thanks and for all that you do in your fight against cancer. My mother was a breast cancer specialist, and so she did a lot of the radiation treatment on breast cancer way back when. She'd be in her hundreds now, and back when only a couple of women were graduating in each graduating class from medical school. But she'd be proud of all the things that you've done and all the areas of accomplishment which you've covered. So keep up the fight. Again, thank you for just letting me share a couple words of thanks with you, and my good friend George there. Take care of him. He's a special guy, George Intom, and he's the one who asked me just to share a little bit with you. But again, thank you.
Thank you. So, of course, we still love Andy Reid in Philly. I'm glad it's May and not February, but okay. So next, we want to have a few remarks from former Ghana President John Kufuor. Can you load the video, please?
Distinguished ladies and gentlemen, I felt greatly honored when I was approached by the Ghanaian oncologist Dr. Beatrice Rafi Adai with the information that your conference would be taking place in Pennsylvania to launch a collaborative onslaught on cancer of all kinds to relieve millions of mankind who are afflicted by the menace. I was asked to join in this launch with a video message as one of the subscribers of this great initiative. My immediate acceptance of the invitation stems from the fact that in my country, Ghana, with just a population of 35 million, we suffer close to 16,000 deaths annually from the affliction. For Ghana, with rather limited technological, professional, and inadequate human resource capacity in its fight against this disease, this collaborative concept will facilitate more access to the reliefs needed to join in the effort. And here, I speak not only for Ghana, but also for all the many nations on the continent of Africa, all of which are victims of the affliction. Further, my desire is reinforced by the fact that I've recently become privy to the plans that the Lancet Oncology Commission has for Sub-Saharan Africa. When I was privileged to be briefed by their lead proponents, Professor David Collingridge and Dr. Mrs. Yafiadai, who intimated that the Commission was planning to set up the USA Ghana Cancer Center of Excellence here in Ghana. I take this opportunity to congratulate all the participants and facilitators of this great initiative. I understand that President Joe Biden himself and Dr. and Mrs. Jill Biden, as well as former President Obama and Mrs. Michelle Obama, are all, one way or the other, going to participate in this launch. Further, I'm happy to learn of President Biden's Cancer Moonshot program, for which he has set the ambitious goal to cut cancer deaths in the United States of America by 50% over the next 25 years, and hopefully to effectively contain whatever traces will be left. My appeal here is for this epochal program to be extended around our entire planet Earth in an affordable and sustainable manner. To all of you participants in this historic conference against cancer in any form, I wish you great success in your endeavors for mankind. And let me end by congratulating all of you and also thanking you. God bless.
Yeah, so we're going to try the Eric Holder video one more time. We think that we may have got it worked out. If not, then we will move on. So let's give it one more try. We'll give them 30 more seconds and then we'll move on. Okay, so yeah, I think they're still having difficulty. So I'm going to bring back Will Ngwa, and so we can move on with the panel discussion. All right, thank you for your patience.
Okay, so we are going to turn to the panel that we have today. We have a distinguished panel. Before we get Kevin and Rob to respond, but we are going to ask the ambassadors to come to the podium and then make their remarks. So we're going to start, ladies before gentlemen, if you don't mind. So I'm going to start with Ambassador Cancer. Let's clap for her, please.
Good afternoon, everyone. Good afternoon. Okay. The energy in the room feels a little bit low. I hope it's not because of the chill and the cold that's out there. I'm looking forward to an energizing session about a very critical subject to all of us. Dr. Wilfred Ngwa and Dr. Stephen Avery, Global Health Catalyst Summit Directors, Your Excellencies, members of the African Diplomatic Corps, my brothers and sisters, staff and students of the University of Pennsylvania, members of the White House Cancer Moonshot Panel, members of the African diaspora, health sector stakeholders, distinguished speakers, esteemed ladies and gentlemen. I'm greatly honored to be here with you all today. At the outset, I'd like to thank the organizers, Global Health Catalyst, for inviting me to participate in this important meeting. I also want to commend the Global Health Catalyst team for their dedication in the fight against cancer and for their readiness to work with needy countries like Tanzania in efforts to reduce the burden of this disease. Distinguished participants, despite the developments in science, cancer is still one of the leading causes of death and single most important barrier to increasing life expectancy in many countries in the world. Even more concerning, cancer cases of all types are rapidly increasing. The GlobalCan 2020, which is an online database monitoring cancer statistics, predicts that the cancer burden will have the greatest relative increase by 2040, especially in low and middle income countries like Tanzania, because these countries have little assurance on health outcomes for cancer for both prevention and treatment, leave alone detection. The Lancet report on Sub-Saharan Africa, which I was fortunate to attend the launch of last year, has predicted an alarming increase in cancer mortality in the region from about 520,000 in 2020 to about 1 million deaths per year by 2030 if no sound interventions are put in place. Distinguished participants, cancer is now a major cause of mortality in Tanzania, being the 5th cause of death among adult men and 2nd among female adults. As of 2020, there were 40,464 new cases of cancer in Tanzania and 26,945 deaths. The cancer incidence is significantly increasing, particularly due to changes in lifestyle. Cancer diseases affecting the reproductive system in Tanzania are highly prevalent, particularly cervical cancer, accounting for 25.3% of cases, followed by breast cancer at 10% and prostate cancer at 9%. These statistics translate that women have an estimated higher risk of developing cancer before the age of 75 compared to men. If current trends are not reversed, the cancer mortality rate among women in Tanzania will increase from a current rate of about 10,200 cases per year, translating to about 6,500 annual cervical cancer deaths, to 16,000 by 2040, and implication of 10,400 deaths. In terms of breast cancer, we're looking at increase of 4,000 cases to 11,200 per year, and with deaths standing, shifting or growing from 2,000 to 5,000. These figures mean that cancer burden is not only a health challenge, but also a socio-economic challenge. That is the reason why meetings and gatherings of friends like this give us hope that there's an opportunity for prevention and control of this disease if we come together and undertake appropriate interventions to reverse the situation. Distinguished ladies and gentlemen, improving the provision of health services, including cancer care and treatment, is among the top priorities of the government of the United Republic of Tanzania under the able leadership of Her Excellency President Dr. Samia Suluhu Hassan. In this regard, the government of Tanzania has taken various robust measures, including the following. 1, rolling out the vaccines against the HPV, human papillomavirus, in 2014, which is a leading cause of cervical cancer. By doing this, Tanzania has become one of the first countries in Africa to roll out the HPV vaccine countrywide. The vaccine is now in the National Routine Immunization Program. Given the fact that Tanzania has one of the highest cervical cancer cases in the world, and this cancer is the leading type of cancer in the country, the decision to roll out HPV vaccines was very crucial. 2, putting in place a policy of free cancer treatment, which has made it easy for everyone to access the treatment and assuring inclusivity. The patients pay for other inpatient treatment, such as surgery and transfusions. 3, launching a national cancer treatment guidelines. These were launched in 2020. These guidelines seek to improve and standardize the oncology care in Tanzania. Additionally, there are efforts to conduct public campaigns on healthy lifestyles. 4, modernizing the National Cancer Center, the Ocean Road Cancer Institute, pioneer of which happens to be with us, which is specialized in the treatment, early detection, teaching, prevention, and palliative care. Apart from that, cancer treatment has been distributed to regional hospitals in Bugando, Kilimanjaro Christian Medical Center, this is in the Moshi region, Mbeya and Benjamin Kappa in the center of the country to provide initial treatments before the patient gets a referral to the Ocean Road Cancer Institute. Moreover, in February 2022, the government acquired the ultra-modern cancer screening equipment, PET-CT scan, and this was installed at the Ocean Road Hospital, making Tanzania among few African countries capable of diagnosing cancer at an early stage. Moreover, CT scan machines have been installed in 26 out of 31 regions of Tanzania during the 2022-2023 year, where cancer patients are now able to be examined and detected in early stages so that they can be treated and cured. This is very different from the situation before, where patients had to make the effort to travel to the few centers, and particularly Dar es Salaam, which is very expensive and difficult in terms of access to care. 6, telemedicine has been established and is being strengthened, and connectivities between regional and national hospitals, where regional hospital doctors are able to send CT scan images and even other symptoms of patients to ensure discussions are held with the specialist doctors from national hospital and those from regional hospitals. As you appreciate, there are not enough specialists, so being able to leverage technology allows us to do more with the few specialists that we have. 7, we have improved drug therapy services by introducing immunotherapy, which uses modern monoclonal antibodies drugs that provide specific treatment for the relevant cancer in terms of targeted therapy. This has reduced referrals of patients to go outside the country and also has attracted patients from neighboring countries, and this is an aspiration of our president to position Tanzania as a regional medical hub. 8, Tanzania is using modern radiation therapy, the intensity modulated radiotherapy, IMRT, which is provided by modern LINAC machines, which have strengthened the provision of services beyond that of 3D radiotherapy. These services, again, are not just servicing Tanzanians, but also patients from neighboring countries. 9 is with respect to tertiary prevention for invasive care, which is available at a few centers in the country, 2 for radiotherapy and 33 for chemotherapy. Surgical treatment for cervical cancer, unfortunately, is not currently available. The country plans to increase the number of sites providing cancer diagnosis from 33 to 91, chemotherapy from 33 to 62, and radiotherapy from 2 to 8 sites this year. So you can see we're very ambitious at being able to get ahead of this challenge. Distinguished participants, you heard earlier about the importance of strengthening multi-stakeholder collaborations, and allow me to express our appreciation for an outcome from last year's Global Health Catalyst Summit, where we're working together to establish a US-Tanzania Center of Excellence for Oncology, ideally by the end of this year, but just over lunch we'll talk about how we can get quick wins and already start to get traction in different areas. And to cut a long story short, the idea here is how we can leverage, one, to scale up what is working, both interventions in country and elsewhere, but also create an environment where we can scale up, test and scale up new models, new innovations, as well as new collaborations, again, to do our best to get ahead of this challenge. In addition to the initial agreement to work on this initiative together with our colleagues and Professor Will Ngwa being very active on the American side, in December during the US-Africa Leaders Summit, we convened the first partnership gathering with different stakeholders, some of whom are in the private sector, others in philanthropic foundations, others are in academia, research institutes, as well as our colleagues from the White House, to explore how we can come together to bring this Center of Excellence in Oncology to reality. I'm happy to share that so far we have managed to secure $5 million in seed grant funding and are now looking to close the gap for another 10 to 15 million. And this is based on best practice in the US. Alone, we cannot fight this disease, which has adversely and continues to adversely affect our economies, is killing our workforce, and continues to undermine our health and development goals. It is encouraging to see that President Joe Biden is also committed to fighting this scourge by, among other things, establishing the White House Cancer Moonshot, which I am told is looking to advance President Biden's goals for the Cancer Moonshot on a global scale, including African countries. As a country with long-standing excellent relations with the United States, and with whom we have been working very successfully on various health initiatives, I'd like to declare Tanzania's interest to be part of taking this important initiative forward. Distinguished participants, in concluding my remarks, I'd just like to highlight or summarize key areas that we think we could take forward in terms of doubling down on collaboration. One, how to improve screening, and not just at central locations or at national levels, but at sub-national levels, particularly district levels, essentially taking care to the people rather than asking them to follow the care in far-flung headquarters of countries. Really is how can we make it easier for patients to seek care as close to their homes as possible. Two, how do we improve basic services at those community levels? Three, how do we focus on, or how can we strengthen primary prevention? Can we have better behavior change campaigns? Four, communication and advocacy to bust myths and promote a culture of annual health checks, regular exercise, and positive health-seeking behavior. As you're aware, in some of our countries, rather than people going to seek what they so-called Western medicine, some turn to churches as well as other practices, thus delaying their access to critical care. Five, again, strengthening collaboration, not just with different stakeholders, but even within governments. How do we bring ministries of finance on board, ministries of education, and even ministries responsible for infrastructure? So for instance, when we talk about encouraging people to walk or run, as we build our roads, are we also putting in place pathways that can encourage and make it easy for our populations to easily participate in healthy activities? Last but not least is exploring innovative, affordable pharmaceutical products, and also just bearing in mind that as we think about how to balance interests, I'd like to highlight one of the challenges, and this is more of the economic side, is as we think about so-called risk behaviors, whether it is smoking or excessive alcohol intake. At the same time, in countries like Tanzania, those are the major industries that are contributing revenue. It's tobacco, right? It's alcohol. And so there's a need to strike a balance because they are significantly contributing to the economy, but at the same time fueling challenges that are undermining our aspirations for better healthcare. Finally, I would like to express my appreciation to all the partners who have been supporting the healthcare sector in Tanzania, including industry, healthcare institutions, the US government, media, academia, civil society, and diaspora organizations. In particular, I'd like to highlight the role that's been played by the NIH, USAID, and Centers for Disease Control and Prevention, and we thank them for their continued support to Tanzania as we try to and continue to aspire to meet the SDGs goal number 3 on good health and well-being by 2030. Tanzania stands ready to work with all of you to ensure healthy lives and promote the well-being of all our people. Thank you for your kind attention.
Let's thank Ambassador again. She usually speaks like a scientist sometimes. Quotes lots of data, in her talk. It's almost like, you're at a cancer conference, truly. Next, we're going to have a welcome Ambassador Robbie from Uganda, another wonderful ambassador who is really interested in facilitating collaborations between the US and Uganda. Welcome, Ambassador. Let's give her a hand, please.
Good afternoon. Thank you so much for this opportunity to be here with you. And if you ask me about technical things or those slides that we saw, if this were an exam, we won't say what I've gotten. But in all seriousness, I do allow me to please extend my sincere appreciation on behalf of Ugandans for this opportunity to come and to listen and to learn. And I guarantee you that there will be a word or two that I'll take back. Thank you also for introducing us to the great American sportsmen so we can practice a bit of sports diplomacy. And so where do we start? Uganda and America, our relationship has been 60 years in the making. And when friends are in your lives for 60 years, they've helped you in many, many ways. We've had PEPFAR, we've had many other interventions. So this is once again an opportunity to work not just with the government, but with the private sector. And for that, we're greatly appreciative, and we don't take this partnership or the possibility for granted. Dr. Young mentioned surviving, but not just surviving, but thriving. For the women in Uganda, this is more than numbers. This is beyond numbers. I've seen these women. I know these women. I have buried these women, and I know they're orphans. What we're talking about is something beyond measure. There's another speaker who mentioned radars and the possibility of screening and early detention. And our reality is that when you look at the women and they've survived, we had a 5-year war, then we had HIV AIDS, then we have, once in a while we get Ebola, then we get COVID. We have all these battles within battles. And every time something comes from the left, the right, the center, they survive. Chances are that they really don't even know that in their bodies, there might be something else they may have to survive. Because we don't even have the basic equipment to scan. We don't even know. We're just hoping. We're just thanking God that we survived whatever else came. So again, I really cannot emphasize how much Uganda seeks this opportunity to give these women a chance to really survive and not just to guess. This is what happens when you don't follow the what you're given to what you prepared. So let me, in the interest of time, let me get back to what I wrote. And also, like I said, I have a bit of public health background, but when I accepted this thing, and then I said, oh my gosh, what am I going to say? But I called the Minister of Health, and she got me in touch with the director of the Uganda Cancer Institute. And through their guidance, these are not my own words, so if they sound very sophisticated, I'd like to own them, but they're not mine. But here we go. So obviously there's an increase in aging populations in Africa, The demographics transition could be fueling a rise in cancers and non-communicable diseases in sub-Saharan Africa. Overall cancer burden in Africa region has grown by 30% in the last 20 years, dominated by breast, cervical, and prostate cancers. Despite this growing burden, cancer remains a relatively low public health priority in Africa, largely because of limited resources and other pressing public health problems, which include communicable diseases such as AIDS, malaria, and tuberculosis. In addition, there's a general lack of awareness among policymakers, the general public, and international partners. This is further compounded by inadequate infrastructure and personnel to manage the growing burden. International collaboration is therefore key in addressing the challenge of cancer, in line with the aspiration of GHC as a win-win for US-Africa global health collaboration as proposed by GHC. Uganda therefore enthusiastically supports and welcomes such initiatives. Since 2015, the East African Community member states are already collaborating in addressing the challenges through the Centers of Excellence model. Uganda, through Uganda Cancer Institute, hosts the East Africa Center of Excellence on Oncology. This is in line with the East African Community Health Sector Investment Priority Framework, 2018-2028. Uganda, therefore, again seeks the commitment by GHC, working with stakeholders at the summit to support establishing telehealth infrastructure in Uganda and to grow US-Uganda collaborations in cancer care with initial focus on childhood and women's cancers such as cervical cancer and breast cancer. Uganda has had a long history of cancer research, highlighted by a description of Burkitt lymphoma. In 1958, a surgeon, Dennis Burkitt, he also demonstrated its response to chemotherapy for the first time. This observation led to the establishment of the Uganda Cancer Institute in 1967 as a collaborative project of the US National Cancer Institute and Uganda institutions. By starting with one high-impact disease and gradually expanding its remit, the USCI has grown as a leading African cancer research institution, able to partner with leading cancer institutes across the globe to advance science. And many times it works with Makerere University. Makerere University is 100 years old. It's Uganda's leading university. And it's also many of the doctors beyond Uganda and actually in the world have studied from there. The Uganda Cancer Institute is also a comprehensive national cancer center offering all cancer treatment modalities in addition to spearheading prevention and treatment research to inform cancer control efforts. Given the high volume of cancers in women and the significant occurrence of cancers in children, there is a dedicated Women's Cancer Center and Pediatric Oncology Service. The Institute has also set up satellite centers and community sites that require connectivity, hence telehealth resources would be most appropriate. The telehealth infrastructure would support linkage to regional cancer centers and lower-level health facilities to allow teleconsultation, improving cancer symptom recognition and referral. Additionally, this would also support the cancer training programs currently established at the Uganda Cancer Institute, gynecology, medical oncology, pediatric hematology, and radiation oncology. This capability could equally be extended for training staff in other member states of the East African community. Therefore, we continue to seek and to plan to organize a cancer conference in Uganda to advance US-Uganda collaborations and for a visit to Uganda with industry and US institutions and organizations to invest in global health and development collaborations between Uganda and the US. The possibility to have a cancer conference in Uganda is most timely. This would be an excellent opportunity to showcase facilities, and we look forward to the roadmap and clear plan. The Uganda Cancer Institute, with the support of the Ministry of Health, can host this conference at the East Africa Regional Center of Excellence in Oncology. The Institute would also use the opportunity to engage cancer care centers in all 7 East African countries. So when Uganda is a population of 45 million, but when you consider all the other East African countries, you're looking at a population of about 300 million. The meeting would also provide a broad view of the burden of cancer in Uganda and East Africa and create opportunities for engagement with potential academic and development partners. This conference would allow us to develop collaborative solutions to the rising burden of cancer in the region. In terms of research, the commitment on collaborations involving University of Pennsylvania, Johns Hopkins, Harvard, and others, Uganda would we would build upon this already ongoing research collaborations with the Uganda Cancer Institute. We are committed to broadening the existing collaborations to include others. Currently, the Uganda Cancer Institute collaboratively undertakes a variety of research, including basic and transnational cancer research, epidemiology, socioeconomic, clinical trials, and implementation research. The Institute has built infrastructure, including a pan-cancer biorespiratory research laboratories and unique patient cohorts. The Institute has a number of international collaborations, including the Fred Hutchins Cancer Center and Washington University in St. Louis, and also St. Jude's Children's Hospital, Duke University, Johns Hopkins Biomedical Engineering, and the door for collaboration remains open. Again, through GHC, we could look at the possibility of training, especially in oncology, health professionals in Uganda, including scholarship support. Treatment of cancer is complex, and the endeavors requiring the highest degree of coordination and not just availability of resources. It requires multiple modalities as surgery, radiotherapy, chemotherapy, and others. However, newer modes of treatment have emerged in the 20th and 21st century, such as immunotherapy, targeted therapies. Therefore, there's a need for high-level training programs. Although the Uganda Cancer Institute is slowly building capacity to manage cancer in Uganda and also contributing to capacity building for the entire East African region, the specialty programs, there's need for more concerted efforts to increase human resource capacity for cancer in Uganda and East Africa. The Uganda Cancer Institute currently has 4 accredited fellowship programs and has plans to increase specialized training in Uganda to meet the ever-increasing demand. In conclusion, I'm about to finish. Working together, we can significantly alter the direction of cancer in Africa. A center of excellence approach can provide leadership for cancer care, control, and prevention in the region. Academic, industry, and development partners can work together to make this a reality. The Uganda Cancer Institute is therefore well placed for this because of its long history and track record of cancer care, research, and training. Ladies and gentlemen, I thank you for your time, and I look forward to the possibilities for doing something for the people of Uganda. Thank you.
Thank you so much, Ambassador Roby. That was really wonderful. And really, you have this, talking about the Uganda Cancer Institute, there's really some clear opportunities to collaboration there. So thank you for that. And we look forward to working with you. So actually, somebody just texted me and saying, you're making these commitments to facilitate things. That's really great, So we're definitely going to follow up on some of those commitments that you're making to help build US-Africa collaborations on this. Next, we're going to have another wonderful ambassador, Ambassador Saleshi from Ethiopia, to come and make his remarks. Let's welcome Ambassador Saleshi, please.
Thank you very much, Professor. Thank you, ambassadors, for your speech. Professors, Excellencies, ladies and gentlemen, Good afternoon. I will not take a lot of time. I will try to cut, given that Her Excellency Dr. Leah this morning has detailed the specialized area of the cancer, and then I will focus on partnership and what we could do together. As it was mentioned, in terms of population, my country, Ethiopia, has over 120 million people, the second populous country in Africa, and has also, incidentally, 120 years bilateral diplomatic relationship with United States of America. So very rich partnership together, including health sector. Cancer is, of course, prevalent in Ethiopia, as well explained this morning's presentations, as well as it cannot be different than from our neighboring countries like Tanzania or Uganda. Over the past decade, Ethiopia has achieved significant healthcare improvements. It has expanded access to healthcare services by constructing more health centers, hospitals, and deploying trained health extension workers to rural areas. Rural areas are mostly the neglected places. As a result, there was focused training of professionals to be deployed in the rural areas where 80% of the population live. The Ethiopian health system has been strengthened through the health sector transformation plan, workforce development, and enhanced supply chain management. In fact, Ethiopia has this tradition of developing a 10-year master plan every 10 years, and also 5 years transformational or implementation plans. So private sector engagement in our recent plan has been identified as one strategic pillar in both strategic documents to improve private engagement in a wider range of activities, including health service delivery, pharmaceutical manufacturing, supply chain management, health financing, health information system, human resource development, healthcare administration, and management. Ethiopia has made, of course, remarkable progress in improving health. As a result, the life expectancy at birth has increased from as low as 45 to 66 years. This notable achievement is mainly associated with improvement in maternal and child health conditions and the prevention and control of infectious diseases. To mention a few examples, under 5 mortality, maternal mortality, HIV infection, malaria-related disease, tuberculosis, especially due to acceleration of the MDG era, significant achievements have been made. In terms of maternal health improvement, through increased skilled birth attendance, expanded antenatal care services, and nationwide awareness campaigns have helped. The effective bilateral and bilateral collaborations with the United States and other international partners, NGOs and private sectors have been crucial for Ethiopia's health achievement by leveraging funding and expertise for various health projects. In health care sector, Ethiopia and the United States have a strong and effective collaboration or collaborative relationships dedicated to addressing various health challenges and promoting the well-being of citizens. Recognizing health as fundamental right, the partnership between Ethiopia and the United States in the health sector is focused on reducing the spread of diseases, saving lives, and fostering a healthier and more prosperous future for families and communities. We are grateful for that. Just to mention some of the long-standing partnership. Why I'm mentioning this? Because we find meaning in it, and we could define also our future collaboration in the partnership between the two countries. The United States, through the U.S. Agency for International Development, has been actively involved in Ethiopia's health sector, focusing on areas such as maternal and child health, family planning, infectious diseases. The United States also supports health system strengthening and the development of workforce capacity in Ethiopia. Of course, we have also brain drain from Ethiopia. We have to innovate how we could make really the previously mentioned brain gain, especially when we consider the number of doctors that are serving, for example, in the MAV area from Ethiopia, maybe as equivalent as the one serving in Addis Ababa. So there is a very significant mobilization of skilled workforce, well-trained people moving to advanced or developed countries. So the importance is really, I want to emphasize, when they want to go back and support their back home communities and people, I think those who are participating here and elsewhere, I should support them. I also go together, also look at addressing this kind of challenge that is created due to various diseases, but also in terms of economics, in terms of really looking at helping Africa. This makes significant meaning. The US Centers for Disease Control and Prevention, or CDC, works closely with Ethiopia's Ministry of Health and other partners to address HIV, tuberculosis, malaria, and other diseases. CDC also provides technical support to meet the national goals to eradicate polio, eliminate measles, and strengthen the national immunization program in Ethiopia. Could we find also meaning for CDC to look at cancer, to address the cancer issue in a very programmatic way? I think it can, but it requires advocacy from this end. Since 2003, Ethiopia has been a beneficiary of the US President's Emergency Plan for AIDS Relief, PEPFAR, which has provided life-saving and antiretroviral treatment, prevention, and support service to millions of Ethiopians. The impact of the United States partnership with Ethiopia in the healthcare sector has been significant. As the leading donor to Ethiopia's health sector, the US government has made substantial long-term investment over the past 2 decades. The partnership between Ethiopia and the United States showcases the importance of international cooperation in addressing global health challenges and fostering sustainable development. By working together, Ethiopia and the United States have demonstrated the potential for positive change and the ability to create a brighter and healthier future for millions. In this partnership, of course, people are involved. In this partnership, institutions, universities are very much involved. So we want to keep that and strengthen this effort. Some areas of collaboration with US universities that we want and have been producing meaningful result. One is in training of selected specialty and subspecialty services in oncology, cardiology, neurology, hematology, and others. These are highly specialized and very important areas. The skill and the knowledge in a country like Ethiopia hasn't penetrated well. Therefore, this is collaboration around this makes very significant meaning. Organize medical missions and campaigns for prioritized interventions. This could be a second type of objective. Third, maybe research and development in public health, clinical trials, and biomedical studies are also very important. Fourth, maybe experience sharing between Ethiopian and US universities. Six, maybe health technologies and innovation in areas of digital health technologies, telemedicine, and the like. As we are aware, telemedicine these days is well practiced, especially with the advent of digital technology. So this could also be the future that could leapfrog Africa because we have limited doctors and the like. Other area is perhaps financing and supporting through investment. So these are a few of the important areas I want to suggest. Of course, due to recent conflict in northern Ethiopia, loss of destruction happened in this part of our country. Now, the cessation of hostility agreement is in place and under implementation. Significant rehabilitation and reconstruction work in Tigray, Amhara, and Afar regions are needed, especially the destruction of schools and health facilities and hospitals are immense, so we have to rehabilitate all those. In those, we look forward for support. We look forward to further strengthening this and commence a new partnership. Ethiopian Ministry of Health would be extremely honored to work with Penn State University and Johns Hopkins and other institutions in the United States. Obviously, Dr. Leah was supposed to come here, but she explained because of her very urgent commitment, she couldn't make it, but she made at least a video presentation. The Ethiopian Embassy, on my side, is willing to facilitate such collaboration of Ethiopian and US institution, industry, and the diaspora. Like Betty Floreza here, who is here in this conference room, and also broadly, many members of so-called people-to-people, Ethiopian origin doctors organized around that. Those could really support from their institution and also mobilizing other friends of Africa and Ethiopia. So, just to mention to you, because why I made this technological recommendation and facilities and etc. For 120 million people, we have only 3 radiation machines in Ethiopia, not more. 120 million, 3 radiations. Of course, the effort is there to add additional 4 radiation instrument to be installed to make it at least 7. But you can imagine the gap. Deliberately, we are putting this radiation instrument in universities who have got, medical faculties, so that it can link both the treatment side as well as the data collection, study, and research. In that same context, I think we could find easy partnership with Penn State University, Johns Hopkins, and the like. Obviously, this speaks very well to achieving the Sustainable Development Goals, as one of the ambassadors implied to it. Not only the health goal, but also, health poverty in the poverty dimension. Goal 1 is also very important. People, when we are talking women health related to cancer, it also addresses the other goal, goal 5. So it can go on in various, it can speak to many development goals that all nations have agreed together. Finally, I have to confess also my other half, my wife, is survivor of 3 years long after cancer treatment, but we didn't manage to get cancer treatment in even diagnosing in Ethiopia. But based on the simple indicator as you have spoken this morning, we traveled abroad to India and got treatment. We had to make 2 or 3 times travel to finalize the treatment. You can imagine how many people could suffer. Not many people have the means to travel outside of their country. And so really what you are discussing today and in these 3 days makes very serious meaning, especially in terms of partnership with Africa. I thank you very much for your listening.
Thank you very much, Ambassador Saleshi. He's clearly very committed as well, to do something to facilitate with Ethiopia. And that's one of those commitments, Saifu. I know you've been taking notes. So he's committed to helping facilitate collaborations with Ethiopia. So thank you very much for those remarks. And like you said, the Honorable Minister was able to talk to us earlier today. And there's clearly, that interest to work together. We're going to have, last but not least, Ambassador Mamadou from Niger. Before I welcome him, I want to say that I'm really excited that he can be here with us today. We're very happy because we know, when we're doing the Lancet Oncology Commission for Sub-Saharan Africa, looking for data on Niger was such difficult. And so, Ambassador, you have a really good opportunity for us, to really create inroads into Niger in building US-Africa collaborations with Niger. And I think that after this meeting, actually when I talked to him about this, he sent me a paper from a colleague on a Lancet that he did contribute. And I was like, great, now we begin to have this. So I think you can really help us facilitate that. So thank you very much, Ambassador Mamadou. We want to welcome you for your remarks. Let's give him a hand, please.
Thank you, Professor. It's not only finding data about Niger that is hard. It's actually finding Niger in the map is not easy one. So that's why I will start by saying, where is Niger? I used to say that Niger is a small country in between Nigeria to the south, which everybody knows, and which we share with Nigeria almost everything. We share history, culture, language. We even share Boko Haram with Nigeria. So we are really very close to each other. To the north, we have Algeria, which also almost everybody knows. Then we have other less known African countries, Chad to the east, Burkina Faso to the west, Mali to the west, and so on and so forth. With Algeria, Mali, and Burkina Faso, we share the ACMI and JNIM. These are two very powerful and very dangerous terrorist groups that, together with Boko Haram, attacks us from all our borders. So far, for the last 10 years, our most important priority is to survive, is to fight these terrorist groups. That security only is taking around 20% of our public expenditure. So we have not the luxury of allocating as much as we would like it to be to health. Our colleague this morning, Miriam, said that most of African countries are not even allocated 5% of their GDP to health sector. I am very proud to report that we do that. I checked. Our GDP is $590 per capita. $590, less than $690 per capita and per year. Yet we spend $31 for health. So we are doing our share. And I'm very proud of it. But I have also to confess that we are doing it thanks to international cooperation. 40% of our expenditure comes from donors, from foreign aids. That's the reality on the ground. So we are doing it, but we are doing it with help. And I'm really here to open a route for collaboration with your initiative, because for us it will be vital. When it comes to health and the topic of our conference, I do not have written and eloquent speech as my diplomatic corps colleagues, so I take remarks for what it is supposed to be remarks. So I haven't a written speech, so I will try to go fast and to give some few points. When it comes to the topic of our conference, oncology and inequality in access to medical care, if my understanding is correct, I think it's more relevant in my country than than perhaps anywhere else for two reasons. Number one, we have huge inegalities and huge gender inequalities. I mean, you can just Google it, you would see we have all of them. We have the rural area, rural-urban area bias. We have gender inequality in everything: education, income, access to health. Less than 20% of women in my country know how to read and to write. I don't think there is a lower rate of literacy in the world than in women at home. Childbearing started between 13 and 15. So when you see a woman of 19, she might have 5 children. So the average fertility rate is 7, which makes us, the highest population growth in the world. We have made some progress when it comes to public health. In the last 30 years, we were able to reduce under 5 mortality from more than 300 to now around 70, which is something very good. We were also able to reduce maternal mortality from something like 900 to now a little bit higher than 500 for 1,000 live births. So on public health, really, we have done whatever we can before we were hit by these attacks, and then all our program have become almost humanitarian program. We have good cooperation with the United States. We have, but when you go to the East, 70% of the portfolio of USAID is humanitarian. We have refugees from Nigeria, from Chad. We have displaced, internally displaced people from our own country, people who can just still live and work in their villages because of insecurity. So we have to take care of them. Everything then goes for humanitarian. So we have really all the inequalities, and it's important if something can be done, and we're trying to do it. The good news is that our economic and development plan for 2022, 2027 is all built to address inequality. And the one flagship development program we have is gender education and girl education. We feel that it's a way to not only to reduce gender inequality, but also to help reduce our demographic growth, which is maybe the worst obstacle we have to improve our GDP per capita. So now when we come to specifically to oncology, we just don't have it. In Niger, we have one center, but it's really much more theoretical than effective. Those who have visited Niamey know that we don't have. If you have cancer, you have 3 options. If you have some relatives or some means, you can travel. You can go to Morocco, to Tunisia, and if you are really well off, you can go to Europe to seek care. Second option is to stay home and to go to health facility. Again, we don't have them. We don't have specialized doctors. In general, we have very few doctors. Now we have young people, sometimes well-trained, but they operate within facilities that have limited infrastructure. You have seen the map showed by our colleague on CT scan and so on. If you look at Niger, if you look between Nigeria and Algeria, you will see it's always yellow, meaning that we have always the lowest rate of equipment. So we are really open to cooperation. What else I wanna add before I go to conclusion? Yeah, we have. I was saying that we have. So the public sector, the government is doing. I was saying that you have 3 options to get care. So you can go overseas, you can go in our facilities or pry. These are the three options we have to face cancer. I will conclude very quickly to save time because it can be a long story. We have limited data, that's true, but again, we have limited data because we have limited facilities, because we have limited access, because we have a very large country, so it may take hours of road, and the road are what they are, to reach a health facility. So to conclude, we are really interested in the oncology program. We have the public sector itself is very interested, and I'm here to be a witness of that. I am open, the embassy is open to help. Our cooperation with the US is very good, even though the bulk is now on security. We have bases and so on, military expenditure. I think it's not for such a public, but we have also US aid and we have MCC. So three things where we can really cooperate. Number one, to substantially strengthen the capacity of our existing oncology center to become not something just nominal, but effective. Number two, maybe to improve the training in cancer-related treatment, diagnosis, and so on of our people. We have a few med school, but I'm not convinced that there is good training, and to cooperate with not only the public sector, but also some non-profit sector we have, including NGOs, and one of them being the foundation of our First Lady. She would have been here if this business of coronation of Charles III haven't conflicts. She's likelihood that she will be here speaking instead of me would have been higher. But that's how history is. So that's it. Again, thank you for inviting me. I'm very open to support. One of our young colleagues is in your team, and we count on people like her to come back home one day and improve our health. I'm sorry for the non-written speech and for the English. Thank you for listening.
That was very exciting just to hear from you, Ambassador Mamadou. And thank you so much for the openness, to facilitate collaborations. I just want to highlight Fatoumata, who is there. That's the young doctor that you're mentioning. She's really been championing Niger. But I saw her, we're launching this World Cancer Day. I was very excited, to meet her. And I thought, that would be a really good person who can work with catalyzing initiatives within Niger. So thank you again for that those wonderful remarks. Like I said earlier on, it's not always normal that you have ambassadors sitting on the same panel with NFL stars. And I think we have to take a picture of this because this is historic, right? But the reason why Calvin and Rob are sitting here is because they didn't just excel in the game we enjoy, right? But they also came, when they retired, they decided that they will be champions for healthcare, even for players who were coming out of the NFL or other sports, but also in general to address disparities. And as Catherine talked about earlier on with engagement, with the White House, this is really a great opportunity, where you can bring people who are really healthcare advocates to leverage this platform to reach communities here in the United States. Because we say global health is local health. We still have to take Calvin and Rob to Africa. So as you're inviting us to come to Africa, we have to, make sure that we come to your countries. And we had visited Jamaica once, and the government was very excited, and they created a lot of opportunities through that visit, just galvanizing attention. So I'm going to welcome Rob and Calvin to the front, and they'll just talk about, their response to Catherine's engagement, and also, any remarks about why this is important, the work that we are doing. I know that you, Calvin, actually has your mom, when you're getting your Super Bowl, sorry, not Super Bowl, your Hall of Fame award, you mentioned your mom, and I think who has also been dealing with cancer. So I think you are really in the environment where, you can really be a big advocate for this. So I'd like to welcome first you, Calvin, and then Rob. Yeah. Let's clap for them, please.
Good afternoon, everybody. I don't have too much written down. I'll be real quick. I just wanted to just want to give my gratitude, to the institutions here, the Global Health Catalyst, obviously the White House with everything they're doing, and just give a little brief, about, the situation my mom went through. It actually, the origins were here in Philadelphia, so it's funny that we're here. But I think everybody here knows that through collaboration, we can go further than anyone can go alone. The goal of reducing cancer by 50% over the course of the next 25 years, that's a big goal. It's a very ambitious goal. But with the weight of the U.S. government and the collaboration with this global health catalyst and the other institutions, it can surely be met. With a focus on screening for cancer, addressing the disparities in order to create access for all, and engaging in more advanced research. Research, I have a love for research, a love for data. Research is like, it's the edge, it's us being on the edge of progress, being on the edge of innovation, and that progress, in this case, countless lives will be saved with that kind of progress. I'm happy to advocate for the Global Health Catalyst here because it's people like you all here today that give us hope for a future without cancer. And coming into these catalysts every year, re-energizes us in our company and the things that we're doing in plant medicine with cannabis. But quickly about my mom, about a decade ago, I was here playing in this city. It's a snow game. Snowed like 8 inches or 6 inches during the game. After the game, my mom was going home. Normal game, we actually lost that game, but mom's on the way home. She slips going into the airport. And from that slip, she finds out that she got pancreatic cancer. And it was really, lo and behold, I guess that was her early screening. But everybody in here knows that pancreatic cancer isn't one that many people come back from. We were just fortunate to be able to find it at a time when we did. So she, 10 years later, she's still here today. But, I've been on, I appreciate it, but like many of us here, we've seen probably both sides of that coin. I've seen it, my mom, obviously, that's immediate family. I have an auntie, who died from breast cancer a year and a half ago. So, we've seen both sides of that coin, and it's the work that you guys are here it's the work that's being done here. These kind of collaborations, that mean everything and will give us a chance, like we say, at reducing cancer for everybody world around. So I appreciate you. Thank you, doctor, for everything you do. Thank you for all the doctors, professors, scientists, all you in the room that are on the same path to create change. Appreciate it.
Good afternoon, everybody. Like Calvin said, I'll be brief. It never ceases to amaze me that I end up in a room with all these smart people and ambassadors and folks like that. It's just crazy. I played football 6 years ago, but here I am nonetheless. Thank you to Dr. Gua. He's been in our world for the past 5 years. We've been a part of the Global Health Summit in some capacity. I know we went through a couple years of the pandemic where we had to be in Zoom, so it's finally good to be back and be in the flesh and to be able to talk to everybody. And just the excitement I have to, be in a place where me and Calvin have been able to build a business and it's continuing to grow and still giving us opportunities to be able to collaborate with the White House and all of you and University of Pennsylvania. And it's just crazy and beyond my wildest dreams of where I thought I would be in this time of my life. So I'm so excited to be here. We started Primitive Group, and it's our vertical cannabis company in Michigan. We also had the dream, really after seeing, coming to the first Global Health Summit of what cannabis and plant medicines had the opportunity to be. So we really focused on that. I think one of the first words I took away from the summit was nanotechnology. And 5 years later, happy to report we have our first nano product that we're going to be able to talk to you guys tomorrow about. So it's definitely been a journey, and yeah, thank you. And for us, absolutely, for us, we just really pride ourselves on being authentic and having an authentic brand. And the one thing that we've released with our new nano product is our line called Primitive Performance. Primitive Performance is our performance line for athletes. But when I look at it, right, it's really our bridge to the next piece, which is, in our opinion, healthcare, right? We look at cannabis and plant medicines differently than most of the world, right? This is how we medicated ourselves, and we're able to play at our top peak performance. And obviously believe that that could be translated into not helping people just perform, but helping people get better from whatever they're dealing with. So just so excited about that. And then collaboration, that word's being thrown around, but when we look at our vision, mission, and core values that we built for our company, we have 13 core values. One of those core values is collaboration, right? So once again, just excited to be in a room to collaborate with so many people that honestly are folks that have done so much more in this space than I could ever imagine. But the fact that I get to rub elbows and ask questions and be a part of it, man, it's just great. And in collaboration, like everything else, everybody's got to know their role, right? And I think our role is to use our platform for awareness and education. And I think that's what we're here to do. And we're happy to serve in that capacity. And, I think we're going to start that off with the education series that we're just building right now. And we're going to be able to do some more of that coming up, here in the next few weeks. So I think we did our first one, but just excited about those, love to be in front of the camera, love to create awareness. And, like I said, love to just use our platform for good. So, in closing, I just want to thank everybody for the hard work. We know from building a startup business from scratch, and we know from playing in the NFL that just progress in general, right? It's not easy, right? It's hard, and there's a lot of ups and downs. There's a lot of, barriers that you have to go through, a lot of hurdles you have to overcome. But, I can tell you, we're living proof of that. Not only, 9 years in NFL for the both of us, but building a startup business that now we've been doing this for 5 going on 6 years. And are being successful. So I want to just thank everybody and just continue to encourage everybody just to stay the course, trust the process, and that, together, all of us together, we'll be able to get it done. And I really strongly believe that. So once again, I'm just thrilled. I'm up here with ambassadors from Africa. It's crazy. But, also just a thank you to everybody who's working on this project. I'm not immune to dealing with cancer in the family. My aunt she's a breast cancer survivor for 25 years, and currently in our company we have one of our team members who was going through a situation with his wife. So we've been supporting and serving his family through this time of transition. Seems like everything is going well, but like Calvin said, right, there's always a flip side of the coin. So we just thank all of you for continuing your hard work, and here's to looking to brighter days. So we appreciate it. Thank you.
And they are always very eloquent, very eloquent. So thank you, Rob, thank you, Calvin. We look forward to collaborating with you, obviously. And, there's a session tomorrow that you get a chance to hear from them a little bit more about the things that Rob just mentioned. But at this point, I think enough, it'd be nice to really have a discussion also with the audience now, and hear some questions that you may have for the ambassadors and for Calvin and Rob, as to think about, addressing cancer and inequalities in cancer. I think that's really important in terms of areas to collaborate. So we're going to give a chance to take some questions from the audience. If anybody has questions. It's a hand behind this microphone.
Can you hear me? Okay. My name is Mehdi Shams. I run a nonprofit. I am a co-founder of the nonprofit. We are providing low-cost healthcare services, mostly in the primary. As of till now, we are doing primary care support for people who don't have anything, middle of nowhere. My question is, when it comes to cancer, They're basically based on our discussion today. There are two major things. One is the imaging thing. We can either develop low-cost imaging machines. The other, in my opinion, the other thing is when we have the existing images, we are reading very few things on the images, but there are a lot more information there with AI and with analytics if we could read those and do predictive analytics. So these are the two things. If we could focus on that, and especially my organization, we are working on that. So how can, and it doesn't require a lot of funding, but what my proposal is, if we could do that predictive analytics, if we can work together, and how can we work together, my question is to the audience and the honorable panel.
Okay, so let me just make sure we understand the question. So this is to say, okay, in terms of technology, what are the areas where we can work together? Is that the idea?
Very specifically, yes, but more specifically on imaging, because there are two things. One is developing those machines. I mean, those whether it's a MRI machine or CT scan or even X-ray machine. That's one area that I think we need, because these machines are very expensive. And that's why the third world countries, it's very difficult to provide those. The other area is whatever limited resources. Let's say if we could do a pattern analysis based on the X-ray, because one chest X-ray can provide a lot more information. And if we use AI tools there, we can predict a lot more information there. So I think we need to start looking into that and collaborate collectively.
Okay. Yeah, so I mean, I don't know, the ambassadors, anybody who wants to take that question? I know it's a very technical question, I think, but you're welcome to, anybody who wants to answer?
Indeed, it's very technical, so for me, I'll pass. But we can share contacts after this, and I will. Someone from the Uganda Cancer Institute should be able to answer your question.
Good. Yeah. Thank you, Ambassador.
Can I take it?
Yeah, please. Yeah.
And yes, it is technical. What I'd like to assure you is most of the continent, with the challenges raised by my big brother from Niger notwithstanding, are very much committed to advancing science, technology, and innovation with the support and coordination of the African Union, and in particular the African Union Development Agency. And in that regard, being able to leverage the fourth industrial revolution and sort of leapfrogging the processes that the more advanced parts of the world have gone through in terms of developing specialized equipment is a priority. So I'd say, one, we welcome engagement on how we can take forward the development of these low-cost imaging machines. What popped to mind immediately was, what can we do with 3D manufacturing, for instance? That already lowers the cost, so it'd be interesting to explore what new technologies are out there that can help us to move faster to developing models which frankly may also be more practical in our environment. As you know, things like dust, etc. So this is why it's very good to involve our research institutions as well. There's usually contextual aspects. For AI and data analytics, again, that's an area where quite a bit of advancement has been made. We now have centers of excellence for AI in the continent, in the neighborhood of East Africa. Rwanda has set up a center for the fourth industrial revolution just focused on AI, but they're not the only country that's dealing with AI and data analytics. So again, we welcome engagement on this so we can share what is happening and then see how what is ongoing can be deployed specifically to this particular aspect that you have highlighted. Thank you.
Well, thank you so much. Yeah. So obviously we see the openness to engage on this. Mehdi, I think that's good. I know you are a big tech guy, so I think you're welcome to bring that to work with these ambassadors.
Are now producing in large scale the electronic devices, and that's a problem. And with all due respect, especially from the White House, representative from White House, we need to develop chips in this country. There is a law, but I mean, when it comes to medical devices, I went to that country 7 times before pandemic. They have developed all the electronic components, and entire world needs to share that knowledge. It's kind of like in a one-way tunnel right now. So we need to invest more on research.
Okay.
Thank you.
Thank you, Mehdi. All right. Any other question? Oh, yeah.
Thank you very much. My name is Oluwatoyin Adewumi, and I am the Executive Director of Tampa Foundation. My question is more on the policy side, and it's to all the ambassadors and first ladies and political figures that are here in the group. I have watched as a lot of data from the continent has been shown on the slide, and on one, from one point of view, it might look like doomsday, but then it's important, since this is a moonshot and not a bicycle shot, for us to begin to think of using what we have to get what we want. And in that, I'm thinking of our human resources, incentivizing our current human resources to begin to look at hematology oncology. And what do I mean by that? They might not necessarily have to go to medical school, but for those who are migrating en masse, what steps are you taking to incentivize them to stay on the continent so that they can work towards reducing the cancer burden? And I say that because I'm also a breast cancer survivor, 6 years and counting. I got my treatment in the US. I needed to have what between my husband and I, we call a Lamborghini insurance. So, I mean, we know the health disparities that happen even here in the US if you don't have the right insurance. So it was a Cadillac, and then I Lamborghini'd it. So anytime I go to the farber, they are ready to tell me and give me anything. Even up until last week, my doctor was telling me of something new where they're gonna do like some kind of billionaire blood work to see if there's still cancer running around in my body. So that's far-fetched. But I'm saying, what are we doing now to scale up education and training, train our nurses, train our doctors? We know that it's breast cancer, that it's burdens in some countries, it's liver cancer. What are we doing to equip them so that they can assist the patient populations that are affected without traveling to India? So that's question number one. Number two, what is it gonna take? And what or how are you helping your presidents to cause them to increase the health budget? Because by the time they focus on maternal infant medicine and malaria and cholera, there's nothing left for cancer. And that's the white elephant in the room that we need to address. Thank you.
Thank you. Yeah. So 2 questions, I think. One is, what will stop us from going to India? 2, how do you increase your budgets to address cancer and healthcare? An ambassador can take that.
Yeah. Let me just say a few things on the first question. I also want to reflect on that. You told us you are like NGO, and also you are producing low-cost machine. You want to deploy in needy countries. I think it's a very good idea. So, but in what way do you want to deploy? Needs some further discussion. Are you interested to bring the manufacturing aspect to one of the countries in Africa? You are most welcome. We have a lot of support instruments in terms of facilitating this kind of investment. Place where to manufacture. There are industrial parks, like in the Ethiopian case, where you can house your production. As long as you are not working for profit, I think it's very, very attractive for the government also to joint venture with your work. In the second dimension, I think expanding information and also looking into other possibilities from the already acquired image. I think it is an interesting idea to discover other type of diseases or doing in-depth research. Looks palatable. So if you want to do it in African context, I think in all our countries, universities are there. As I informed, the 3 radiation machines, for example, are housed in university teaching hospitals. So you can easily collaborate and really work on that. I think in this end also, it is an interesting idea to unpack from a single image a number of information that informs various diseases. On the issue of why we go out of, if I understood the question correctly, on
the budget, can you increase your budget?
Oh no, it's not leaving Africa. It is about.
Oh, they are going to India. Yes.
If it is about the doctors who left Africa.
How do we stop people from going to India, so they say?
Yes. The brain drain, there are many factors. Sometimes there are who come for further education may remain here to further deepen their understanding and application of, for example, if you bring someone who's specialized on a very important area, but the machines may not be there, he may not apply his knowledge, then that individual may prefer to remain here. What I was requesting was really, in order to make brain gain, I think institutions, first of all, look at their staffs who came from needy countries in Africa, and then encourage them actually also, and also provide them some leave time and the like, so that they can really establish collaboration and also mobilize other staffs actually to work with them as a means of brain gain. You can imagine also how expensive for someone to go to elementary school, high school, medicine faculty in the poor country, how much it costs us, and then when the poor country loses that kind of skilled force, then it's real hurting. So that is then how do we pay back, for those people of African origin? They should also think how do they pay back to their original communities who have actually invested some resource. It's about thinking, providing support and service for really people needing in their back home. I am not asking for exodus to go all people back home, but when they have sabbatical leave, when they have research leave, when they have their summer leave, they can use this kind of opportunity to provide 1 month, 2 months, if it is sabbatical, 1 year service in their original country. This is just an idea. I think some people are really doing that way, also helping a lot. Yeah.
Thank you. Yes. One more question? Yes, President Goma.
He's going to get one for me. That's okay. That's all right.
Thank you very much for the presentations to the ambassadors and the panel altogether. Cancer kills more people globally than AIDS, TB, and malaria. That's a fact. So it's a huge problem. I wonder, and I have been wondering for so long, that the global community has funds for AIDS, has funds for malaria and TB, but when it comes to cancer, there is hesitation. Maybe what we should do is collaborate with the ambassadors and everybody to see if a global fund for cancer can be created. And then regarding the moonshot, I remember the BBC once interviewed me and a lot of other people about when President Bush was leaving office and asked me, what do you think is the most contribution that President Bush did for the African continent? And I said, pepper funding. I mean, I see it every day. It has really changed a lot. See, the decision to have pepper funding has changed the landscape of HIV/AIDS in Africa. Now, with the moonshot, a lot of things are being done, but is there a possibility of having similar funding for Africa? Even if you call it another name, but at least it's a funding that is directed to cancer. And then locally, I think we are talking of universal health coverage. We still need to have insurance, national insurance funding to assist the governments in funding as one of the financial options. You see, in most of Africa, people covered by insurance is less than 10%. So even if cancer was covered by insurance, it means the majority of cancer patients wouldn't be able to access cancer services. But one way we could have improvement is to have access to health insurance. That is a policy issue, and ambassadors can help us through the governments to have health insurance for the population so that we can increase access to service to people. Once you are covered by health insurance, then it means that you can access service when service is available. So it's two issues, about health insurance and about funding directed for cancer to fight this increasing problem, which, as I said, is a bigger problem than three things combined. It kills more people than AIDS, malaria, and TB. And if you look even at the non-communicable diseases, cancer has more second cardiovascular diseases in terms of deaths related to non-communicable diseases. Non-communicable diseases, as we're speaking today, are overtaking communicable diseases. So these are problems that are increasing. So how can we collaborate and redress this so that at least there is order in the way we think about this disease? Thank you.
Okay, we're going to give you a chance. We are really running out of time, so I'm going to let the ambassadors have a chance to answer that question.
One more question.
One more? Okay. Berlin, is that you? Yes.
Hello, good evening or good afternoon, everyone, and thank you so much once again. My name is Briley Chitsonge. I serve as the Pan-African Parliament, the legislative body of the African Union Food Security Ambassador on the continent. It's more maybe just an answer to bail our ambassadors out with Prof. Ngoma, what he was asking for. It's almost the impossible that you're asking the ambassadors to do. Truth be told, we all know governments are broke right now. they have to be run as business entities. So what we could ask the ambassadors to do is to find private entities, like the two gentlemen, the far right that you're sitting next to, come up with initiatives, then maybe they can go on a drive to raise funds, which you can then put in the countries to set up some of these institutions. But relying on government to say health insurance, where's the government going to get money from? That is like a dream that you will never live to live, Dr. Ngoma. So I think that it's all in our hands now. What can we do to help government? I mean, so I stand here as your ambassador of food security. So there are other things in the agriculture sector that we can also drive to say, what can we help on the African continent in terms of agriculture, where they can actually, it's now the backbone of any economy in the world, as you all know. So that's where we can actually leverage on. And of course, partnering agriculture and the health sector would help immensely. We all know if you get all the micronutrients, the health budget will certainly decrease. I've always often said that these cancers we're talking about, could it be something that we're not eating, or could it be something that we're eating? So it's also a matter of like looking along those lines and see how we can all help together. So I just thought I would bail my counterparts here for you as your ambassador. Thank you.
Thank you, Braylene. And Ambassador wants to answer. Please go ahead. Yes.
Thank you very much. Thank you for bailing us out. So this is the thing. When we talk about collaborative research and innovation, already, for example, in Uganda, somebody mentioned the cancer cabinet. Well, our president has put together the science cabinet. So he's focusing on scientists. He's focusing on research. More so when we went through COVID, we were also trying to look for different areas of vaccines. Traditionally, we've had different ways of treating different elements. So that's also an area of research. And on the other side of the coin, we also have Ugandan researchers, and would welcome the collaborations. Yeah. But the thing is, sometimes we just don't have, we're there, but we just don't have enough. It's like saying you have a car, you're going somewhere, but the capacity is what we're looking for. So we just want a bit of a faster engine so we can go faster. This is not to say that even within among countries, amongst the East African countries, there are certain things that we jointly do research on. But to say that it's just a one-sided coin, and why are we not there? There are many things that are possible, and that's why we're here saying, how can we look at this in terms of investment, in terms of partnerships? Because the other thing also, fundraising is good, but the reality is it sustainable? So we want collaboration that's going to be sustainable. So perhaps if you want to come and start a factory, maybe in exchange, government can give you the land. We want to put something in there. We're not looking for handouts. We're looking for proper partnerships, because through these, that's where sustainability really can be an issue. Thank you.
Thank you. Yes.
Ambassador Mamadou?
I want to say a few words on two questions. The first is about how to retain people in our countries so our health system could be better staffed. This is really a typical type of trying to get a simple answer to a question that is complex. People migrate for many motives, and people who migrate are not only in health sector. In every sector, people do migrate. And again, if you look at the global picture in some of our countries, remittances that people who have migrated to developed world are sending back is much bigger than ODAs. So they participate in countries' development more than what aid is doing. So there is really not kind of simple question. The same way as medical doctors, you go deep in the issue to get the best way to treat people. These questions do not have just a kind of side effect answer very quickly. These are very, very complex. The same way, the issue of how to fund global fund versus classical development funding. If you go to the literature on the evaluation of global fund, most of them are almost failure. They are not doing as good as classical way of delivering. They are not doing as good as all or as the best classical way of delivering financing, including health sector. There are many examples of classical delivering aid to health sector to fight diseases, to fight under 5 mortality, to improve immunization that were more successful than global funds. And if you want a bilateral, I can give you very clear examples. So there is just, there is really no simple, easy answer to these questions. That's my feeling.
Okay, one more remark, please.
Yeah. A number of questions were asked, just want to touch them. One is on collaborating for global fund. That's also what I tried to allude to my speech, a paper-like funding mechanism to roll out the moonshot would be an excellent provision, focusing on needy countries. Many of us in Africa need that. On the insurance issue, we are at the very beginning or an infant stage. The income of people is not really that much adequate to put up insurance mechanism. In a few countries, health facilities or health support are freely given, like education and so on. We are not at that stage that the majority of the community be supported through insurance mechanism. But we started it, for example, in Ethiopia. Those who have resource and money can participate in that insurance scheme. In terms of the research, I think in Africa, mostly as a policy, for example, in Ethiopia, we focus on applied research than basic research. We can't catch up with the basic research really to penetrate into the basic ones, but for example, once you discover through very rigorous research a certain medicine, then applied research can take it to African context because of agroclimatology or genetics or things like that, can be well done in collaborative manner. As we don't have a resource, for example, to go to basic research that tries to find the water somewhere in the moon or in another planet, we don't do those kind of research because of resource scarcity. Is it not? Yeah, so, but applied research are very, very useful. Yes, agriculture production and productivity are very important to secure or become liberated in food production. Through that, we can have better nutrition for building healthy society in our part of the world. So this is what I want to add. Thank you.
I see we're winding up. I'll just add with an appeal, particularly with respect to coming up with innovative financial inclusion solutions, one of which would be coming up with alternative instruments for providing national insurance. When you take into account that most of our economies are in the informal, are dominated by the informal sector, you don't have a basis where insurance is being contributed to on a monthly basis. And so we need new products that adapt to where our people are and not where we would like them to be. So if you are in, for example, in the agricultural sector, then the cycle should follow the cycle by which you're able to receive funding. How do we also reduce the contribution amounts so that people are able to contribute perhaps on a daily basis and not on a monthly basis? Fintech in Africa is taking off. It's the fastest growing startup sector. We're seeing billions of dollars go into it, even now during the global crisis that we're experiencing in different ways. And therefore, this is another area for collaborating with non-traditional health or healthcare stakeholders to see how they can contribute to closing the gap and addressing some of the challenges that we're facing that in the entirety can make the ecosystem function. And lastly, just with respect to special budget interventions, just building on what has been said, there is a school of thought as well that we should not be isolating funding for single diseases. How can we have a much more integrated system? Yes, there are areas of distinct difference, but there are also areas of universality. And as you know, as my countryman from Tanzania, where we're trying to really decentralize access to services, and that means that at least from a primary healthcare perspective, we're able to cover most of the issues that are facing our people. And that frees up the budget to be able to double down on specialist care, which is very expensive. Quite frankly. But when you have isolated programs that target only specific diseases, that makes it much harder to close the gap and ensure that we are lifting access to basic quality healthcare for everyone, while also increasing on a targeted basis how we can tackle these tougher challenges and which are creating more deaths. It's just how can we make the ecosystem function better? Thank you.
Thank you, thank you. So we're a little bit over, but we want to ask one final question of the panel before we close, and the question is actually for you, Calvin. I know that your product is focused on pain relief, and I know as a player there was a lot of issues with recovery, and also as cancer patients. Dealing with pain is an important issue for pain management. Can you talk a little bit about the research that you're doing or some of the focus that your product is looking at for pain management?
Yeah, I'll start with, why we created the products. As Ross spoke to earlier, we're just trying to be extremely authentic. And we just started with products that we use while we're playing professional football. There's a lot of topical creams and a lot of rehydration solutions that were used. So, we started with an ORS, oral rehydration solution, and a topical transdermal topical cream, both of them featuring nanotechnology. And really just in an effort to get the particle size small, just to create a more efficacious and consistent product. But mainly, when we were playing, we use those products to, really just affect our function on the field so that we can move. But there was nothing in it. There were no anti-inflammatory properties within the oral rehydration solutions or the topical cream. So being able to add that to the products that are being used currently still to today on the field, is going to be a huge step for those that are looking to, really just elevate their game and recover faster. But at the same time, there's still a process that we have to go through and getting, NSF for sports certified so that we can approach these leagues. But we're in the process of doing those things. But all that comes with CGMP certification. So just making sure that we're aligned to be in a position to, when, the leagues and other professions come to call, we're in position to answer.
Yeah. Thank you. Thank you. So we're going to put a close to the panel. I would like to thank once again, can we give them a round of applause? So we would like to take a picture with the panel. So if Will, you can come up. Also wanted to invite the chair of our department, Jim Metz, if you mind coming down. And Casa Daraj also, who is chief of surgery at Children's Hospital, as well as many other things. He has developed programs in Ethiopia also. Beatrice and Saiful, would you also come to the stage? Who's taking the picture?
Yeah, and one thing I want to also add to Stephen, I mentioned that, the investment, private sector, these are gentlemen who are private sector. So collaborating with the ambassadors, that's going to be one thing that we can do, right? Like visit Africa, we have to do that. Yeah. Stay right here, please. One more request. So the diaspora, Catherine, you need to come up. Catherine needs to come and join this picture. And then if you are from the diaspora organization, because we're looking at engaging the diaspora, please can you join for one last picture? Diaspora organization leaders, beginning of the engagement. Yeah. All right, thank you, everyone. Thank you. Sharing the picture. Recording?
I was so lonely. I feel like no one to do.
When?
Now. Thank you. Okay, all right.
I think so.
Okay, all right. We have the dinner. You want to join us for dinner? It's going to be here in the hall.